A very good morning to one and all present here. Welcome to Dubai. On behalf of the organizing committee, it is my absolute honor to welcome you all to day one of the Emirates Pathology, Digital Pathology and Cancer Conference. It gives me immense pleasure to see such a distinguished gathering of medical experts, researchers, clinicians, and healthcare professionals who have come together with one purpose to share knowledge, exchange ideas, and health and advances innovations in pathology and cancer research. Today marks the beginning of an exciting journey of scientific exploration. We have an exceptional lineup of speakers who will cover diverse and crucial aspects of pathology, histopathology, oncology, digital transformation, and medical advancements. I am Dr. Ekaparna Hazarika. I have flown all the way from India. I am undergoing my fellowship in oncopathology at the State Cancer Institute in India. Something about the UCG conferences. They are a group of conferences which offer a diverse range of events, including meetings, conferences, workshops, and symposiums. The dedicated team is committed to leveraging cutting edge technology, understanding the unique needs of organizations, and adopting the basic ideas and strategies to deliver exceptional experiences. As pioneers in event management and collaboration, UCG is a full service event organizer specializing in the academic and industrial sectors of medical, clinical, healthcare, life sciences, pharmaceutical, and environmental sciences. The commitment to quality, 24/7 support, and competitive pricing sets them apart from the competition, providing with the ultimate event and meeting experience all under one roof. At UCG conferences, it is prioritized to ensure that the event is selected best suited to the goals. I would like to extend my sincere gratitude to the organizing committee, the speakers, and everyone who has worked tirelessly to bringing this conference to life. Also, welcome and warmly thank each one of you for joining us today for the unwavering dedication to pathology, digital pathology, and cancer, and for the profound impact that all of us has made on the lives so far. Today marks a significant milestone in the journey of the UCG conferences, an opportunity to connect, share insights, and reflect on advancements in the fields. So let us take full advantage of this occasion to learn from one another, build new partnerships, and raise the practices of pathology, digital pathology, and cancer to unprecedented heights. Some points to be noted before we start the day. The speech timing for keynote speakers will be 30 minutes. Speech timing for other speakers will be 25 minutes. Poster timing will be 15 minutes. I am delighted to introduce the distinguished keynote speakers of the Emirates Pathology, Digital Pathology and Cancer Conference taking place on the 3 days, that is September 2nd to the 4th. So first of all, I would like to introduce Dr. Rohit Mehta, who is here with us, and Mr. Omar Ali. So now we'll begin the session. Let's start with our first speaker, Dr. Neha Kamble from India. I'm passing her to the stage to deliver the speech on diagnostic conundrums of myelodysplastic neoplasms in a digital era.
Good morning, dear all. I'm Dr. Neha Kamble. I'm Assistant Professor, Dr. D.Y. Patil Medical College Hospital and Research Center, Pune from India. And I'm the founding director for CNCS Global Healthcare and president for Medical Charitable Trust Foundation. So the topic for today is diagnostic conundrums in myelodysplastic neoplasms in a digital era. So we go a little back to the basics, first time jitters. So there are a few precursor, conditions for diagnosing myelodysplastic neoplasm. So we begin from CHIP, CCUS, ICUS, IDAS. Then you have MDS, and then you have AML, then you have MPN, right? So there, it's a workflow of diseases that happen. So it always starts from CHIP. So CHIP is clonal hematopoiesis of indeterminate potential, wherein there is no cytopenias, but yes, you have a clonal population which is showing you abnormal mutations, right? So this is a normal population which is having no detectable somatic mutations. I think yeah. So it's a normal population which has no somatic mutations, detectable somatic mutations. Due to some driver mutations, you start having clonal populations, right? So the prevalence for CHIP is still quite low. It is around 10 to 40% in the entire population studies that happens. So there's a lot of genetic predisposition, a background of inflammation, cytotoxic exposure, immune attack, and smoking. And then out of the population of the CHIP, either you have low frequency mutations which do not progress into anything, they just stay as CHIP all throughout their lives. However, there is a other population that transforms into AML or MTS or MPN with the progression of mutations. The second progression is CCUS. So it is clonal cytopenias of undetermined significance. So yes, you have clonality again from CHIP, and now you start having cytopenias as well, right? So clonal cytopenia of undetermined significance, the progression risk is around 10 to 20% per year. It also depends upon your VAF, your number of mutations, and your driver gene mutations for the progression into AML, MDS, or MPN. The third category is MDS. So this is how a normal progression of disease happens. So MDS is considered quite a rare disease. However, back in India at my unit itself, in the last 1 year, we've had around 12 to 15 cases. Around 20 actually, but then we couldn't work up the rest because again, due to financial restraints. But yes, 15 out of those had quite the molecular mutations and quite the prognostication models that we could have. So this is the progression through MDS to AML from a normal population to pre-MDS, which includes your CHIP and CCUS. MDS, which is again low risk and high risk, we are going to cover that, and then progression into AML. So the formal introduction of MDS happens now. So myelodysplastic neoplasm. So irrespective of it is called as MDS, the long form is still MD, myelodysplastic neoplasm. It has come up in the WHO 5, right? Underscoring the neoplastic nature of these diseases and harmonizing the terminology with that of myeloproliferative neoplasm. So just for the phonetics, sake of phonetics, the short form is still kept as MDS. However, now it is called as myelodysplastic neoplasm. So it's a unified framework for defining cytopenias, and it is now adopted. These definitions include hemoglobin of less than 13 in male, less than 12 in female for anemia, absolute neutrophil counts of less than 1.8 into 10 to the power 9 per liter for leukopenias, and platelets less than 1.5 lakhs. So dysplasia in one or more myeloid lineages is the morphological hallmark of MDS. So as compared to the previous WHO classification, the recent classification, it's fine even with you have a one single lineage dysplasia or a two lineage dysplasia or a three lineage dysplasia, right? So the threshold is still 10% for all the lineages and across all MDS types, as well as for myelodysplastic myeloproliferative neoplasms. So dysplasia may be accompanied by an increase in myeloid blast. However, the blast percentage will always be less than 20 because as the moment it crosses more than 20, it becomes myeloid leukemia. And then there are a few myeloid leukemias with a few genetic aberrations which do not need the cutoff of 20%, like acute promyelocytic leukemias or translocation or inversion 16. Myeloid lineages affected by cytopenias are not necessarily the ones that manifest dysplasia, right? So you may have anemia in the periphery. However, you may have megakaryocytic dysplasia on the bone marrow. So these two are not related. Yes, cytopenias in the periphery and dysplasia in either of the lineages in the marrow. So how do you diagnose a case of MDS? So it primarily relies on these three, the tripod of diagnosis, the counts, the morphology, and the genetics, right? So the counts indicate your ineffective hematopoiesis. Your morphology indicates your functionally abnormal cells, right? So I want you to stress here that morphology, they are there, but they are functionally abnormal, right? So they are functioning, but abnormally. And genetic disorders where you have clonality. So the counts, so this is routine investigations and findings. I am sure everybody must be doing this. So you do routine blood tests, CBC, PBS. Yeah, serum LDH levels, serum vitamin B12 to rule out nutritional deficits, history of drug exposure, hematinics, and things like that, and so on and so forth. So diagnostic evaluation should always include microscopic examination of adequate bone marrow and peripheral blood smears coupled with one or more of the following: your chromosome analysis, your conventional karyotype or FISH, your mutation analysis, your next generation sequencing, and your immunophenotype, if necessary, by multi-parameter flow cytometry. So flow cytometry, I'm not too keen on advising on a case of MDS because quite a lot of times the diagnosis is quite clear on morphology. Investigations and findings. So dysplasia, as we've already discussed, it's one of the morphological hallmarks. The threshold is set at 10, and the myeloid lineages affected by cytopenias are not necessarily those that manifest dysplasia. And you need to have a 500 cell differential count in a marrow and 200 differential count on peripheral blood. So this is the common morphological findings or dysplastic features that you see in erythroid, granulocytic, and megakaryocytic series. So the first picture, I believe if you can see, over here, we've put an arrow. This is a trinucleate erythroid cell. This is a binucleate erythroid cells. Here you have loss of granules in the mature form. So you can very clearly see the earlier forms have cytoplasmic granules. And as the cells mature, you start losing the granules. So this is also a type of dysplastic morphology in myeloids. And megakaryocytic series wherein you see multinucleation, hypolobation, mononuclear micromegakaryocytes, and widely separated lobes. So this is quite the common morphology that we encounter day in and day night on our MDS cases. So one more image, I believe we've already gone through. So the genetics, now we come to the second part, that the genetics is quite complex and widely heterogeneous. So usually what we order is a 41 gene panel, a DNA study panel for our myeloid cases. It covers all your mutations right from RNA splicing to your DNA methylation, your chromosome modifications, karyotype abnormalities, your DNA response and repair gene mutations, signaling pathways, coenzyme complex, transcription factors. So this is the whole gamut of mutations that you see in cases of MDS, and it is quite important because these are very imperative for prognostication and risk stratification of cases of MDS, right? So this is the WHO Heme5 classification that is currently being followed. So you have myeloid precursor lesions, clonal hematopoiesis, as we've already discussed. So this was a provisional entity in the previous WHO, and now this is taken up as a final entity into WHO Heme5. So clonal hematopoiesis, which includes your CHIP mutations, your myeloproliferative neoplasm, and these diseases that are covered under that. You have mastocytosis, and then you have myelodysplastic neoplasm. So it is broadly categorized into myelodysplastic neoplasm, defining genetic abnormalities and defined morphologically, and myelodysplastic neoplasms of childhood. So we are majorly covering the first two, not the childhood. So myelodysplastic neoplasms with defining genetic abnormality majorly covers your MDS with low blast and 5q deletion, your MDS with low blast and SF3B1 mutation, MDS with biallelic TP53. So now you may say, now when we are looking at 41 gene panel on NGS, why do we see only these three, right? So because these three are the major contributors to the disease progression, your response to therapy, and things like that. So others are also important, but these are the major ones, the commoner ones, based on which prognostication becomes easier. It becomes easier to treat the patients, right? The second category is myelodysplastic neoplasms defined morphologically. Again, you have MDS with low blast, MDS hypoplastic, and MDS with increased blast. So the previous terminology was excess blast. So now the terminology is increased blast. So we covered the first one, MDS with low blast and 5q deletion. So this is a myeloid neoplasm with cytopenias and dysplasia. Chromosome 5q deletion may or may not be accompanied by your 7q monosomy 7 or 7q deletions. Typically, the blast will be less than 5 on the marrow and less than 2 in the peripheral blood. And this is the commoner finding that you see. So you see a lot of megakaryocytic dysplasia you see with low blast and 5q deletion. So anemia of macrocytic thrombocytosis is quite commonly seen with 5q or added 7q deletion. Thrombocytopenia is quite rare. Bone marrow is usually normocellular, hypocellular, and megakaryocytes are usually increased in number, normal to decreased in size, with conspicuously non-lobated, hypolobated nucleus. In contrast, dysplasia in erythroid granulocytic is less pronounced. The second category is low blast with SF3B1 mutation. So whenever there is SF3B1, ring sideroblast is the first thing that should come to your mind, right? So myelodysplastic neoplasm with low blast with SF3B1. It presents with cytopenias and dysplasia characterized with ring sideroblasts. So less than 5% again bone marrow blast and less than 2%. Absence of 5q, monosomy 7 or complex karyotypes and SF3B1 mutations, right? So the ring sideroblasts have to be more than 15%, and the ring sideroblast morphology should cover more than 1/3 of the circumference. The next category, so this is quite a new category, your biallelic TP53 inactivation, because when TP53 mutations were studied, they realized that a host of combinations and permutation combinations that can happen with TP53 mutations, right? So here again, it is less than 20% bone marrow blast and less than 20% peripheral blood. It's a usually complex mutations and cytogenetics. It's a multi-hit TP53 mutation. So you can either have two TP53 mutations, that is both the alleles, or you can have one TP53 mutation with a VAF of more than 50. You can have one TP53 and the other allele having a copy number or neutral loss of heterozygosity, or you can have one TP53 mutation with 17p loss, right? So this is a whole lot of mutations, permutation combinations that you see with TP53, and you need to be very sure when you're seeing these kind of cases. So MDS biallelic TP53 takes precedence over MDS 5q and MDS SF3B1. So irrespective if you have all of these three mutations, if you have TP53, it falls into this category of biallelic TP53 inactivation. The next category defined morphologically, wherein you do not have any molecular mutations, but yes, the morphology is strongly suggestive of MDS. So again, with low blast, as we can see, less than 5% bone marrow blast, less than 2% periphery. Any genetic landscape except SF3B1 and multi-hit TP53, because then it shifts to the upper category. Myelodysplastic neoplasm, hypoplastic. So this is quite a different category, because for MDS, typically you have pancytopenia in the periphery and you have a hypercellular marrow. So these typically have a hypoplastic marrow. So whenever you are suspecting MDS and you don't find any cells, or you find a hemodiluted or a hypoplastic marrow, please have this diagnosis still in your differentials. So cytopenias and dysplasia characterized by significantly decreased age-adjusted marrow-cellularity as described on a refined biopsy. Hypoplastic is driven by a selective growth advantage of somatically mutated clonal hematopoietic stem cells or progenitor cells. So hypoplasia, it is usually driven by a T-cell mediated immune attack on hematopoietic stem cells with oligoclonal expansion of CD8 T cells overproducing interferon gamma or TNF alpha. So significant overlap with PNH is quite common, and aplastic anemia is quite common. When PIGA gene mutation is demonstrated in the absence of bona fide features of MDS, classification of PNH is preferred. So bone marrow cellularity, it is assessed on your refined biopsy or on a quality clot. If you find it difficult to have adequate materials on your bone marrow procedures, it must be significantly decreased. So there's a cutoff for this, right? For patients younger than 70 years, it should be less than 30% of normal cellularity, and patients more than 70, it should be below 20%. Dysplastic features are identified in one or more hematopoietic lineages. Mix may be scattered or form loose clusters with usual features of megakaryocytic dysplasia, including small size and nuclear hypolipidation. And the presence of micromegakaryocytes is quite rare. So this has to be noted. Whenever you are looking at a hypoplastic marrow, you are not looking at micromegakaryocytes, whereas micromegakaryocytes are quite commonly seen in the rest of the MDS categories, right? The next is myelodysplastic neoplasm with increased blast. So increased blast IB1 and IB2. So first is was excess blast 1 and excess blast 2, earlier than MDS or WHO Hem5. So MDS with increased blast 1 is more than 5% blast, but it is less than 10% in the bone marrow, and more than 2, but again it has to be less than 5% in the peripheral blood without significant reticulin fibrosis. Okay, the second category is MDS with increased blast. So increased, surely you have more than 10, but again less than 20, because we don't want to mislabel a case of acute leukemia, acute myeloid leukemia as a plain MDS. So blast will be again less than 20% in the bone marrow and more than 5 and less than 20 in the peripheral blood without significant reticulin fibrosis or with the presence of organs. The next category is MDS with increased blast and fibrosis. So this is one of the category. The reason why we were specifically stating that there should not be reticulin fibrosis, because once reticulin fibrosis sets in, it is then labeled as MDS with increased blast and fibrosis. Now, this is quite the rarest of the rare entity that happens, right? And diagnosing this means you have ruled out all the gamut of differential diagnosis that can happen for MDS, right? So this is pretty much considered a diagnosis of exclusion, wherein you have more than 5% blast but less than 20% in bone marrow and more than 2 and less than 20% in the peripheral blood with significant bone marrow myelofibrosis, grade 2 or grade 3, and any genetic landscape except SF3B1 and multi-hit TP53. So why we are studying so much? Why are we into molecular and cytogenetics so much? Why? Because the prognostication models have been developed on those lines, and there have been better access to targeted therapies for MDS. So the prognostication started right from 1997 to the IPSS-M in 2022. So IPSS, the earlier categorization was majorly on your morphology, your cytochemical stains, your cytogenetics slightly more. So IPSS are considered your cytogenetics quite seriously into the prognostication models. But after 2012, IPSS-M is the prognostication model that is currently being utilized, which takes into consideration your NGS findings, your molecular findings as well, along with your karyotyping. So this is quite important because your prognostication model. So if you have SF3B1, it is indicates quite a favorable prognosis. So you have targeted therapies available, the patients respond quite well, and there is no progression of the disease. A natural or unknown prognostic impact is this group of mutations that you see, and this prognosis is so the reason why TP53 has been searched so much is because it gives quite a bad prognosis to the patient. So TP53 mutations, EZH2, DNMT3A, ASXL1, RUNX1, SRSF2, CBL, all of these mutations need to be looked after because they indicate a rapid progression of the disease. So this is quite a lovely diagram. So I work with a few units in Europe as well, and there was a PhD student, and she was explaining there was a research project that she was doing, and I should give her the credits. I'm really sorry I forgot her name. She was a very cute girl, and this is the drawing that she made for me because she wanted to explain what exactly she is doing in her PhD. So PhD topic was quite extensive. It's a different discussion altogether, but I found the diagram quite beautiful. So to the center sits CCUS. So CCUS is when you have started developing your cytopenias, right? So because for MDS, you need to have some cytopenias. If you do not have it, is still chill. So for a case of MDS, if you have clonal cytopenias and none of this, it is still CCUS, right? So once your blast cutoff is more than 5, you go into MDS excess blast. If it is less than 1, it is either of these 4 categories, right? And if there is no mutation, it is just CCUS. You don't have MDS deletion 5q, you don't have low blast, you don't have SF3B1, you do not have TP53, you can still label the patient as CCUS. When the blast cutoff is more than, I believe I'll have to move this. Yeah. So when the blast cutoff is less than 20, it is still in the category of MDS EB, excess blast. So either 1 or 2 depending, but the blast cutoff has to be less than 20. And once it is more than 20, it becomes AML. Between 20 and you have myelodysplasia related changes and you have blast population, increased blast population, you can label it into AML MRC, myelodysplasia related changes, right? So this is quite beautiful that she explained me, and I really thought this deserves to be in a textbook because it makes your understanding quite easy. Because a lot of blast percentages, less than 5, more than 5, less than 20, more than 20, it becomes quite difficult. More than 20 is 5, but even when you have less than 20, there are a lot of categories that need to be considered. So this is quite beautiful that she made, and I hope this comes up into any of the textbooks ever in the future. Okay, so the new modalities of testing, now that we are into a digital pathology conference, I believe this deserves a mention. So the new modalities of testing is flow cytometry. So there's OVATA scoring, which is commonly done. Quite a few institutions do it. Honestly speaking, we do not follow OVATA scoring. We do not do flow cytometry for an MDS cases. So this is a newer score that has come up, MDS PB13. So it's a score which combines the detection of FCM aberrations in different cell populations to suggest the presence of MDS in blood. This score offers a preferable test reliability as a part of integrated diagnostics in blood, and it might represent a less invasive tool. So this is a blood-based flow cytometry study, not a marrow-based study, to guide further diagnostic steps in patients suspected of having MDS. So MDS 13 score, it must be validated. However, it is still in research models, and it has to be validated in a multi-center setting, which is planned within the ELN IMDA. So there's a link. If you want, you can please get in touch. I can share you. So this is the scoring system. Beautifully, they have covered the IPSSM category as well into their scoring system. So it becomes easier to integrate it into your routine diagnostics. MRD in MDS is NGS based, and MDS exhibits not only DNA based but also heterogeneous aberrations related to immunophenotype. So cell-free DNAs, as we are commonly doing liquid biopsies, we are doing for MRD analysis. I believe I'm reaching my time limit here. So your liquid biopsy cell-free DNA-based studies are there for MDS, and cytogenomic-based detection for MDS for MRD in MDS. So CB and FISH are conventionally used, and single nucleotide polymorphism chromosomal microarrays are the newer important tool in identifying a chromosomal imbalance and loss of heterozygosity that are not detected by standard cytogenetics methodology. So in lines with this is optical genome mapping. So optical genome mapping is basically considered next generation cytogenetics. So as NGS is next generation molecular studies, optical genome mapping. So thankfully, I'm pursuing my PhD in the same topic, optical genome mapping in MDS, and hopefully we will start our study in the next 6 months. So OGM is a novel non-sequencing based technique. The advantage of OGM over the molecular is you do not break your DNA. So you're looking at the genetic material at the whole. So that's the advantage. But yes, again, this is not a singular technology that can be used. It has always to be used along with your NGS findings. So we do not have a validated protocol for OGM or detection of mutations by OGM and using them into your routine clinical practice. But yes, there are a few studies which have made very good progress with the studies, and hopefully I will have some good findings by next year. So it enables detection of all SVs by evaluation of patterns generated by fluorophore tags labeled to specific six base pair sequence motifs within extremely large DNA molecules of more than 300 kbs. It is unaffected by repeat sequences. So MDS is characterized by a high degree of somatic mutations. We've already known this. So they have a lot of SVs. So SVs are typically at times missed by your routine molecular techniques of detection. So SVs are defined as genomic alterations which are greater than 50 base pairs that encompass your copy number variants, your deletion duplications, insertions, inversions, gene rearrangements, complex genomic alterations, and your copy neutral loss of heterozygosity or uniparental disomy. So this is just a workflow of OGM, how it happens. I must say this is still not in clinics, but I hopefully in the next few years it is surely going to be. So you extract high molecular weight DNA, you label with your fluorophores, you linearize your labeled DNA molecules, and your images are recorded. So a lot of bioinformatics, a lot of digital modality involved into the entire processing and the entire interpretation of samples. And then you plot circus plots, which are then compared with your whole genome interfaces. So thank you so much. Please feel free if there are any questions. I'd love to have them. Yeah. Okay. Thank you. Thank you so much. Thank you for being so patient.
Yes. And I'm sure every one of us find it very difficult to diagnose such cases, but it was so beautifully put in front of us. I would like to request Dr. Neha Kamble ma'am to please stay back for the certificate. And I would like to request Dr. Rohit sir to come forward and hand over the certificate.
Thank you. I need to come ahead?
Yeah, then come down.
I need to come down?
Yeah, yeah.
Okay, okay.
Good.
You'll have to get me again. Yeah, that's okay.
Always.
Thank you.
Thank you so much. Our next speaker is Dr. Bidhan Chandra Das from India, and he'll be delivering his speech on 10 case reports on ophthalmic pathology, histopath with IHC, that is immunohistochemistry. This is a very rare case sequence, so I'm sure everyone will be excited to see what he's going to present.
Distinguished chairpersons, organizing committee, distinguished faculties, and all the delegates present out here. I'm Dr. Vidhan Chandra Das. I'm currently working in Sri Shankaradeva Netralaya, Guwahati, in India. Uh, at the outset, I would like to thank the organizing committee for giving me the opportunity to present these cases. These are basically few ophthalmic pathology cases. So moving on to the first case, a 3-year-old female presented with painless blind left eye, and she was diagnosed elsewhere as retinoblastoma. The perception of light on the affected eye was negative, and in the other eye, it was normal. There was white pupillary reflex also noted in the affected eye. So this is the B-scan sonography. So showing high reflective mass lesions arising from the posterior pole and extending anteriorly towards vitreous. So suggesting the differential diagnosis of diffuse retinoblastoma and Coats disease. So as the patient there is loss of vision, so enucleation followed by silicon ball implantation was done. And this is the bisected specimen of the eyeball showing a triangular whitish plaque-like tissue at the retrolental portion extending posteriorly towards the optic disc. And this retrolental plaque attached to the ciliary body at each end. And this is the gross microscopic photograph of this posterior white stalk showing persistent hyaloid artery. This is also known as Buckminster papilla. This is the histology of the anterior component. This is also called Mittendorf dot, where we can see hypervascular tissue with zones of calcifications. There were numerous thickened and obliterated blood vessels noted, which are probably the primitive tunica vasculosa lentis of the primary vitreous. And this is the cut section of the hyaloid artery of the Warminster papilla. And this is the attached retina to the plaque. Retina is disorganized here, thrown into many folds, and there are some cystoid degeneration within the nuclear area of retina noted, and there is loss of polarity of the retinal nuclear cells. And however, there was no small blue round cells, immature round cells, or rosette formation noted in this case. As the retrolental plaque was attached posteriorly, so there occurred tractional retinal detachment at the peripapillae area, which leads to separation, stripping out of the retina from the underlying this uvea. This is the uvea and this is the sclera. And this is the curtain of the optic nerve. So based on the histomorphology, this case was diagnosed as persistent hyperplastic primary vitreous, which is also known as persistent fetal vasculature. And this persistent hyperplastic primary vitreous often it masquerades as retinoblastoma clinico-radiologically. Although it's a congenital condition, the symptoms may not be evident immediately after birth, and it becomes noticeable during infancy and childhood. Now moving on to the case number 2, a 66-year-old male presented with bilateral orbital swelling for last 7 months, which was gradually increasing, painless. However, on the left-sided swelling was a bit more than the right side, and there was also associated bilateral submandibular node swelling noted. This is a multi-detector CT scan where we can see diffusely enlarged, homogeneously enhancing lacrimal glands bilaterally. So blood investigation reveals very high serum IgG4 level, which was 80.2. The common autoimmune antibodies like anti-nuclear antibodies, anti-SSA, anti-SSB, RA factors, and anti-CCP were within normal limit or negative. This is the histomorphology of the left orbital mass, where we can see diffuse proliferation of inflammatory cells along with few zones of fibrosis. These are the lacrimal glands which are destroyed by the inflammatory cells. Hyperview shows plenty of lymphocytes as well as plasma cells. And some of the plasma cells, they were secreting immunoglobulins in the form of Russell bodies. So immunohistochemically, this mass stained positive for CD138, which is a plasma cell marker. CD20, CD3 both came positive. So does this tissue, it contains both T as well as B lymphocytes. And IgG4 came positive, which was more than 50% of the plasma cells. Both kappa and lambda came positive, which means there is no light chain restriction, and this is not a clonal condition, rather reactive. So considering the immunohistochemistry and histopathology, it was diagnosed as IgG4 related orbital disease. Now, the case number 3, a 45-year-old male presented with severe diminution of vision with proptosis in the right eye for last 1 year. Perception of light was negative in the affected eye, and the other eye it was normal. intraocular pressure was raised in the affected eye, which is 35 millimeter mercury, and the other eye, it was normal. This is the B-scan sonography, where we can see this is the almost total retinal detachment, and there's a subretinal elevated mass having low internal reflectivity arising from the posterior aspect of the intraocular cavity extending anteriorly. So the enucleation was done. This is the gross specimen of enucleated eyeball, and this is the whole mount histosection, where we can see one whitish mass arising from the posterior aspect extending towards the vitreous. This is the histopathology, where we can see a proliferation of smooth muscle cells arranged in short fascicles within the choroid. And this is the disorganized, degenerated retina present on the surface of the mass. And high power view shows the cells are bland looking. There is no atypia having eosinophilic elongated cytoplasm. This proliferating smooth muscle cells are swirling around the choroidal blood vessels. Some zones show wavy nuclei. And we cannot see here any atypia, necrosis, or mitosis. This is the sclera, which is unremarkable. On the left-hand side, we can see this is the proliferating mass. The retina was stripped out from the underlying tissue. This is the iris and ciliary body, which were unremarkable. Angle of the anterior chamber was open, and cornea showed scarring. Immunohistochemically, this mass stained positive for desmin as well as smooth muscle actin, but S100 came negative, although it has some wavy nuclei. So it was diagnosed as intraocular choroidal leiomyoma, probably arising from the choroidal blood vessels, tunica media of the choroidal blood vessel. Case number 4, a 55-year-old female presented with proptosis and inability to close the right eye for last 1 year, and there is perception of light negative in the affected eye, and the other eye is normal. So CT scan revealed heterogeneously enhancing expansion lesion in the right orbit, causing pressure effect in the surrounding structures and proptosis, and there was no intracranial or intrasinus extension seen. So enucleation was done along with the entire mass. This is the mass. We can see that this mass is attached to the optic nerve, as measuring around 7 into 4.5 into 5 centimeter. This is the histopathology of the enucleated eyeball, where we can see retinal detachment. This is the retina, that's the underlying uvea, and the sclera. This is the histopathology of the globular orbital mass, where we can see nest of proliferating polygonal cells separated by thin fibrovascular septa. At the hyper view, cells are monomorphic, having centrally located nuclei and abundant eosinophilic cytoplasm. Whole formation is rare, and some body is not seen, but some zones show clear cell changes. The necrosis, mitosis, and atypia not seen. Immunohistochemically, this mass stain positive for epithelial membrane antigen as well as vimentin. So it was diagnosed as optic nerve sheath meningioma, WHO grade 2. Any meningioma arising from the optic nerve has a very high recurrence rate, and there are some clear cell changes. So we label it as WHO grade 2 instead of grade 1. Case number 5. A 8-year-old male presented with painless blind left eye for last 7 months. It was associated with physical sense. Perception of light was negative, and fundus examination could not be performed as the lens was cataractous. B-scan sonography shows reduced axial length with thickening of the retinochoroidal layer and partial retinal detachment. So eyeball was enucleated. This is the gross specimen, where we can see a whitish mass at the lateral wall of the intraocular cavity, just behind the intraocular lens. This is the histomorphology. The retina is thickened, is thrown into many folds, and disorganized, and some bone formations also noted. Hyper view shows altered nuclear laminations and numerous rosette-like structures. And there was also associated serous retinal detachment. This is the serous fluid underneath the retina. Retina was detached at the uvea and sclera. And this is the curtain of the optic nerve, which was unremarkable. So it was diagnosed as retinal dysplasia. Next is case number 6. A 3-year-old female presented with proptosis in the right eye for last 2 months with diminished vision. This is a CT scan where we can see a mild hyperdense retrobarbar mass in the right orbit, which involving the optic nerve, and this optic nerve could not be demonstrable separately. So orbitotomy was done and the mass was excised. This is the mass along with the thin portion of the optic nerve. And the scanner view shows this is the optic nerve, and from the optic nerve, there's a mass arising from the surrounding tissue. Hyper view shows numerous bipolar cells having long elongated cytoplasmic process set in a fibrillary and microcystic stroma. Numerous Rosenthal fibers noted. However, there is no atypia, necrosis, and microvascular proliferations noted. Immunohistochemically, the mass stain positive for glial fibrillary acidic protein and S100. So it was diagnosed as pilocytic astrocytoma arising from the optic nerve. Now, case number 7, a 67-year-old male presented with proptosis in the right eye for last 6 months associated with mild pain. This is the MRI showing a heterogeneous isointense mass lesion at the inferior lateral quadrant of the right orbit, pushing the eyeball. So orbitotomy was done, and this mass was excised, and this is a lobulated mass measuring about 3 into 2.5 into 2.5 centimeter. Histomorphology shows disorganized proliferation of the oval to spindle cells interspersed with numerous slit-like blood vessels set in a fibrocollagenous stroma, and extensive areas of necrosis noted, some fat-forming zones also seen. Hyperview shows cells are pleomorphic, having hyperchromatic nuclei, high NC ratio, prominent nucleoli. Some mitosis also noted, which was around more than 4/10 high power field. This is the immunohistochemistry profile. Vimentin came positive here, however, EMA was negative, CD34 was positive, CD19 was focally positive, and STAT6 was also focally positive. So it was diagnosed as malignant solitary fibrous tumor of orbit. Now, case number 8, a 56-year-old female presented with gradual loss of vision in the left eye for last 1 year. Perception of light was negative in the affected eye. On the other eye, it was normal. There was also conjunctival hyperemia seen, along with a nodular blackish mass at the upper lip margin of the same eye. This is the fundus photography where we can see one pigmented mass at the posterior wall of the intraocular cavity. B-scan sonography shows an elevated nodular mass along with partial retinal detachment in the arising from the posterior wall extending towards the vitreous. So eyeball was enucleated. This is the gross specimen of enucleated eyeball. There was partial transillumination defect noted. The bisected eyeball shows one blackish nodular mass arising from the posterior pole and at the retinochoroidal layer. However, the scleral cut looks unremarkable. There is an unstained tissue under polarizer where we can see a brownish pigmented mass in the retinochoroidal layer. This is the sclera. Histology shows presence of proliferating tumor cells having abundant melanin pigments. The hyper view of this mass shows cells are oval to spindle shaped, a bit monomorphic. There is no significant pleomorphism. There are some more photograph. We can see oval to spindle shaped cells. These are some more photographs. So this is the melanin bliss photomicrograph of this tissue after treating the tissue with 1% potassium permanganate and oxalic acid, by which we can wash out the melanin so that we can appreciate the nuclear morphology in detail. So we can see the cells are spindle oval to spindle shaped, but there is no significant pleomorphism out here. But peripherally, some zones show epithelial morphology having abundant cytoplasm. So we used HMB45. So it came positive. But HMB45, we cannot differentiate a malignant melanocytic lesion from the benign one. So we use one additional marker, which is PRAM, preferentially expressed antigen in melanoma, which came negative. PRAM is a nuclear marker. So this cytoplasmic, color, brownish color is due to pre-existing melanin pigment, which gives a false positive impression. The pattern of the optic nerve was unremarkable, free of tumor, and this is the histomorphology of the associated lead mass, which shows features in favor of dermal nevus without junctional activity. So it was diagnosed as choroidal melanocytoma or nevus. So choroidal melanocytoma is also known as magnocellular nevus. Both are in benign conditions. If epithelioid cells having centrally located nuclei, benign morphology are predominant component, then we'll label it as choroidal melanocytoma. If spindle cell, type A spindle cells are predominant component, then we can say this is a choroidal nevus. Now, case number 9, a 58-year-old male presented with gradual loss of vision with mild pain in the right eye for last 7 months. Perception of light was negative. This is the B-scan sonography. We can see a nodular mass rising from the posterior pole, extending towards vitreous. So enucleation was done. Transillumination defect noted in the enucleated eyeball. Gross morphology shows a color button appearance mass rising from the posterior inferior quadrant of the intraocular cavity. And this mass, it breached the bruised membrane and extended towards the vitreous. This is the photomicrograph of the end-phase view of the flat mount preparation of the retinal pigment epithelium, where we can see single layer retinal pigment epithelium. There is no cellular crowding and hyperplasia. So we can rule out the adenoma or adenocarcinoma arising from the retinal pigment epithelium, which is highly the melanin pigmented. So this flat mount preparation, if there is cellular crowding, so it may masquerade as melanoma. So histopathology of the choroidal mass shows proliferating tumor cells having melanin pigments. Hyperview shows cells are epithelioid, predominantly having hyperchromatic nuclei, open duct chromatin, and prominent nucleoli. So both HMB45 and PRAM came positive here. PRAM is a nuclear marker. This is a carton of the optic nerve, which was free of tumor. This is the sclera, but however, the sclera was infiltrated by the tumor cells. This is the vortex vein, where we can see a suspected pigment cells at the edge of the vortex vein. And this is spongiform scleropathy, which was noted at the base of the tumor. This is a feathery degeneration of the sclera due to fragmentation of the collagen. It results from the activation of the matrix metalloproteinase 2, which facilitates the scleral extension of the tumor. So it was diagnosed as choroidal malignant melanoma. And there was also metastasis noted in the other eye 2 years after the initial treatment. So unfortunately, patient didn't survive. But the earlier case, the case number 8, we have followed up the patient. Patient is still doing fine, and till date there is no evidence of metastasis and recurrence noted in the choroidal melanocytoma nevus cases. Now the last case, case number 10, a 4-year-old female presented with diminished vision in the right eye. However, the perception of light was present to some extent. The lens was dislocated and conjunctival neovascularization noted. This is the montage of the fundus photograph showing hazy view. The optic disc and the macula could not be appreciated here, and there was suspected retinal detachment along with disorganization of intraocular structures noted. So eyeball was enucleated. This is the B-scan sonography and the enucleated bisect eyeball, where we can see a tiny mass arising from the ciliary body extending towards the vitreous. This is the histopathology, where we can see the tumors arising from the ciliary body. These tumor cells are arranged in interweaving tubules and containing some eosinophilic secretions and set in a myxoid stroma. This is the disorganized retina. Hyperview shows cells are pleomorphic, having enlarged hyperchromatic nuclei, moderate amount of cytoplasm, resembling metastatic adenocarcinoma. Some tubule formation also noted, which may recapitulate the primitive medullary epithelium of the neural tube. The optic nerve, curtain of the optic nerve was circumferentially, this is involved by the tumor cells. This is the central retinal artery of the curtain of the optic nerve. We used Elsian special stain, Elsian blue, which came positive due to presence of stromal mucopolysaccharides. Immunohistochemically, this must stain for nestin, neuron-specific anolis, and vimentin. So it was diagnosed as medulloepithelium of the ciliary body, WHO grade 3. Intraocular medulloepithelioma is categorized into three grades: grade 1, grade 2, grade 3. Grade 1 is a benign, grade 2 progressive, grade 3 is a malignant. And this medulloepithelioma intraocular commonly arises from the ciliary body and inner lining of the optic disc. In contrast to the central nervous system medulloepithelioma, which is invariably malignant, which is not so in intraocular medulloepithelioma. So that's all. This is my institute where I am working. Thank you.
Hello to everyone. I would like to call Dr. Robi again to hand over the certificate. So we would like to end this session here, and I'm sure everyone was benefited from the last two talks. We do not get to see that many cases of ocular pathology, and Dr. Das has laid a very good presentation of 10 cases. And also the myelodysplastic syndromes, we do not get to see so many cases. So I'm sure both the presentations were equally helpful and enriching. So we'll head over to a coffee break for 20 minutes. After that, we'll meet up again. Thank you. Thank you.
Yeah, hi, Dr. Umar. How are you? I'm good. Good.
I remember last time you were looking very good.
Next, let's say conference.
Yeah, Hill Holiday. Just
Yeah, but it's under your
I went past this.
renovation.
I just want to double check everything's okay. Because everything I'm on afterwards. Um, and are you using Click or are they just pressing?
You just press it because we kept it the MacBook, but it's not working currently, so we just remove it during the coffee break.
Okay. Okay.
Please have a look.
I was going to hide the slides, but it doesn't let me. You can't change it here, can you? That's all right. I can go past.
Yeah.
But that's all good. So it's all fine.
You can switch it.
Um. Yeah. So I was going to hide this one slideshow. It doesn't let you change it. I think it's pretend.
Or else you can skip it. You can.
Yeah, I'll skip it. Yeah. Okay.
So
Okay.
it's fine.
It's all good. Thank you so much.
Okay,
Thank you.
Please hear.
Let's get a picture of us. Yeah. Now you come. Yeah, like this. Okay. Yeah. I'll find a seat.
The next week.
Okay. Yes, that's the next week. You're here, right? So, did you watch? Have you got a badge? You got a car? You got a car? Yeah, yeah. Yes, it's not. Yes. Now, so she will post this. Hard to okay. I mean, you have to go. Okay, sure. Oh, yeah, yes. Sure. Right. Actually, that's right. I did it last year. It's nice. Change. Is it goes on? I didn't figure it out. Yeah, go to the seriously. Yeah, so I think. Yeah. Oh, no. That is all the. Because it's 17 hours, right? Based on. Peaceful. Peaceful. It's actually increased. You are. Oh, okay. Oh, that's not sure destination. Oh, you're right. Maybe they'll also be doing it on really feels on it. Oh, yeah, much better. Okay, yes, absolutely. And they say they're only looking at this point. Yes. Did you just write that? Well, actually, it's in the post. Or Tom Knight. I was kind of this. Oh, so we have to look at the company. Oh, you must be so tired. Yeah, I'm getting there too. Oh, you think it? Yeah. Yeah. Yeah, I'll be here to play the now with my son, and I like to swing more this now. It's almost just be talking about it, man. It go to wake it up. I thought about it. I'm thinking, what could we get better? I think it's just like six small, it's 2 years. Oh God, oh, to be yeah, yeah, yeah. Oh, she must miss you then. Yeah. Thank you. Oh, really? That was nice. You must let's hear it. Yeah, yeah, yeah. Oh, oh, well. Okay. Yeah. Yeah, for sure. It's an interesting talk. I mean, it is. I would get easy, something that's what I believe so yeah, that's it. It's about oh, okay. Oh, it's going like this. Oh, yeah. Oh, okay. Yeah, oh, yeah. Yeah, exactly. So you know, I will now, yeah. Actually, I know this. It has to be relaxed. Yeah, exactly. Yeah. You don't have. Probably. Yeah. Oh no, it's it's great. It's for sensitive so we're starting patients and starting to go over the synoptic reports and kind of different patients. It's mainly just helping wrap their head around the diagnosis. I don't think they know what they're looking at, but then they can kind of slide it kind of empowers them under their head. So it's kind of I said I don't know what's more I said I gotta say that now I'm just now doing very well. Because he's never only here my senior wife that he's keep it he's I was talking to his lawyer and I mean what something in comes with knowing what such chairs and India got severe hemophilia to me. So it's just they so yeah, so I wanted to get him where it was can I and how it is there. And, well, then you have people think, yeah, yeah, I wish I had I'm glad I know, but I wish I could be more into cheese cakes and that's why it's coming from parents. Yeah, of course. Yeah, of course. But then if she sees you, start crying or yeah. Yeah. How long was it? Was it 1 hour? Okay, so 1 hour was thinking. Oh, nice.
Hi, welcome back, everyone. I'm Lindu Vimish from Group Health and Medical Services, Qatar Airways. So I hope you all had a refreshing coffee break and recharge your energy. So let's get started again with our next session. Our next keynote speaker is Dr. Rohit Mehta from US. I'm passing the stage to deliver his speech on utilization of SAVI-SCOUT radar versus wire guided localization in neoplastic breast lesions. A retrospective review comparing margin status and re-excision rates. Please, Dr. Rohit.
Morning, everyone. My name is Rowan Mehta. I'm a surgical pathologist from upstate New York at the University, Upstate Medical University. Today I'll be, thank you. Today I will be discussing utilization of SAVI-SCOUT radar versus wire-guided localization in neoplastic breast lesions. I have nothing to disclose. So with the advent of more sensitive screening modalities, the rates of discovering non-palpable breast lesions have increased significantly. And the key to success of removal of these lesions is using breast-conserving surgery or wide localization, is accurate localization of the tumor. The goal of breast-conserving surgery is to remove the tumor with adequate margins while leaving as much of healthy tissue as possible. Current localizations allows the surgeons to plan an ideal incision and dissection pathway, as well as margins depth. Multiple techniques have been developed over the years to improve surgical outcomes, i.e. decrease rates of positive margins and reoperation, decrease costs, and improve patient experience. So there are numerous localization techniques that we use for non-palpable breast lesions. Now, the gold standard is wire-guided localization, developed in the mid-60s. Another idea is intraoperative ultrasound localizations. This actually has the best margin status thus far. And there's no preoperative procedures. And I'll go into a little bit about all of these. Radioactive localization, magnetic localization, radio frequency identification, and radar reflectors. The ones that we use in my institution is a wire-guided localization. Intraoperative ultrasound localizations, we're kind of straying away from that, and radar savvy scouts. So wire-guided localization was developed in the 60s. It's very low cost and widely adopted around the world. The wire needle is placed preoperatively into the lesion under sonogram or mammographic guidance. As you can see on the right here, this is the gross specimen from our bench, and this is a needle localization wire. Now, the downsides of this is that the preoperative management of these patients, the patient has to come in early, the radiologist has to insert the needle, and then that can a lot of scheduling delays. So that's the main concern of it. But the main one is also the possible wire migration. So in the area of interest, if you have very adipose tissue in your breast, as we know, it can migrate. So you may not get the tumor all out. Intraoperative ultrasounds is still widely used today. Again, the advantages is direct visualization. It is low cost, and there's no preoperative invasive procedures to do it. Now, the only bad thing about this is it's very operator dependent. So you've got a new surgeon, he or she may not be able to use your intraoperative ultrasound as good as you would for the needle localization. And it's only useful for lesions visible by ultrasound. So sometimes if you have microcalcifications or DCIS, or you may not present as a tumor mass, you may not be able to use the ultrasound. And in neoadjuvant therapies, you may just have fibrosis and no more visible tumor, and they may just be taking out the area of fibrosis as well. Radioactive localizations, again, this was introduced in the 1990s. You have got seed localization and radioactive occult lesion localization. Now, the good thing about this is that you can have this plant the seed days in advance, almost 60 days half-life for the seed. So patient undergoing neoadjuvant therapy, you can place it prior to the neoadjuvant therapy, and then the seed will, 60 days you have for it to excise it. But radiation safety is a big problem with this, and it's prohibited in a lot of countries, and you need to have at our institution need to have the environmental people come in and make sure that the radiation, the seeds are thrown away on time. A magnetic and paramagnetic localization, again, this is not really used much in our institution, but the main concern is the artifacts on the MRI of the surrounding tissue. So it has problems, again, except in neoadjuvant therapy. And as we all know, neoadjuvant therapy is used in a lot of carcinomas now of the breast. Radio frequency identification tags. It's something, again, we don't really use in my institution, and this is all new to me when I was preparing this report. But the consideration of this is defibrillations and pacemakers. You're not supposed to have those. And as we know, patients with the older they get, the more likely to have breast carcinoma, and a lot of these patients are on pacemakers. So again, this is the major consideration of the defibs and the pacemakers. Radio reflector localization is new at our institution. It's called a Savvy Scout radar. And what it is pretty much, as you can see here on the right, it's a little radar with two little antennas that's activated by infrared light impulses by the probe. So pretty much, for lack of a better word, it's like once it's inserted, you have like a wand that you inside of the patient's cavity in the breast, and it'll go like beep, 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 beep. Then when you hit the area, and then it'll dissect around it. Now, the big disadvantage of this is the cost of the equipment and training. A lot of our surgeons are starting to use this, and there's a big learning curve for this. So sometimes if they don't place it in the appropriate area, it may migrate again. And nickel allergy is another problem with this. Here we can see, so at our institution, every time we get a breast specimen, we will always x-ray it, even if depending on doesn't make a difference of the mode of localization. So here you can see the Savvy Scout is right here. It's pretty large compared to some of the other things that are deployed once you take the biopsy. So my study is the use of Savvy Scout versus wire-guided localization, and we wanted to analyze the margin status. So we had 429 neoplastic breast lesions in 419 patients. Some patients had multifocality. This is why the numbers don't match. And we used 4 different surgeons, and we looked at the patient's age, whether it's lumpectomies, partial mastectomies, and re-excisions. The Savvy Scout radar was used in 204 cases versus the wire-guided localization in 225 cases. The neoplasms that we looked at was invasive ductal carcinoma, invasive lobular carcinoma, ductal carcinoma in situ, and invasive mammary and mucinous tumors. Invasive mammary is, some of the micropapillary entities or ones that we can't really use. Like if E-cadherin was negative in it, and it's like a mixed tumor,
He forgot.
Yes, people are watching virtually.
I'm sorry.
People are watching virtually.
Ah, okay. 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 I was not aware there's virtual attendance as well. So what is cryopreservation? We're discussing, and that's one of the cornerstone of storing samples for long term. It's essentially storing material at below minus 35 degrees. Now, why is that temperature important? This is what we call a glass transition temperature. And it's a minus 35, and it's typically when you have the polyols in water. Colder than TG, water ceases to move and enzymatic activity stops, which is what we require for long-term storage. So whenever the temperature goes above TG, then you have physical activities and in the cell and continues. So for long-term storage, why do we look for that? We use it for research therapy, diagnostic drug development. Essentially, if you're preserving sample structure and physiology. So the sample we store today, we want to be able to look at it in 5, 10 years and have the same activity. So typically we use liquid nitrogen to get below minus 35. We currently prefer vaporization, so it's not liquid nitrogen, it's vapor phase we store it. And the temperature is quite stable at minus 190 degrees temperature, and it can be preserved for 2 to 3 weeks even without fresh liquid nitrogen, depending on the technology that you're using. But that's essentially gives you the peace of mind that you've got long-term storage. So why do we cryopreserve, and what are the steps we take to make sure that the integrity of the cells are in good condition? Cryopreservation, or whenever you freeze a cell, for example, you get nucleation, and it's very stressful for the cells. You end up seeing osmotic pressure, increased solute concentration as the water is pulled out of the cells, gets dehydrated. So what did the osmotic pressure do? There's loss of intercellular water through osmosis as proportional to the rate of cooling. So we really try and do a balancing act between cooling at the right rate, not cooling too slow, not cooling too fast, because if you cool too slow, you end up with high concentration of salts. If you cool too fast, then you can damage the surface of the cells or the cell structure. So there has to be an optimal rate, depends on the cell volume, membrane permeability, but typically it's 1 degree per minute. Then we know that the cell is being cooled at a temperature at a rate that will keep the integrity of the cell. So we use cryoprotectants. DSMO is a typical one. This adds the cell's solute concentration. It reduces ice formation within the cell and protects the membrane permeability. However, it is toxic, so the rate of cooling and thawing is critical. And when you thaw the cells, there are certain procedures you follow that protect the cell integrity. So stabilizing critical biological property is why we preserve, because we want, as I mentioned earlier, the cells to be in good, or tissue for that matter, to be in good condition. So we want to slow down the degradative enzymatic activity. And we know that thousands of cells, I mean, you're all cell biologists, I assume, that you've done, you know, there are thousands of proteins in plasma in all cells that will degrade the cell. And all these proteins are their nature is degraded nature. So reducing temperature reduces the protein activity. Again, with water, same thing. When you drop the temperature, we are turning the water into crystalline perspective, amorphous crystal. And we try to keep it below minus 35, so it's cold enough not to prevent reactivity. So again, principles are the same. We preserve at minus 35, and we use it using 196, and typical samples, cells, blood cells, sperm, embryos, all forms of medication. Okay, so how do we do that? We use liquid nitrogen, and I'm sure so many of you have noticed. I've used it before. I've seen it in labs. It's quite stable. It allows it to. It's prevalent in 78% of the Earth's atmosphere. At 1 atmosphere, liquid nitrogen minus 196. However, one thing to keep in mind: the expansion rate is about 800 times to 1. So whenever you have a room to hold liquid nitrogen storage, you need to make sure that the room is quite large. You've got sensors to make sure that there's any nitrogen leakage, so you're able to detect it and be able to react to it. A misconception is when you store a sample in dry ice, if you're trying to keep it below TG, and actually when you look at the rate at which the warming of a sample, if you look at a 2 ml and a 1 ml, the purple line shows you, the graph shows you how fast it reaches TG, it crosses TG line, and how fast it crosses either the ambient, so you put it in a tube on a counter, or we put it in dry ice, and you'll notice, which is counterintuitive, that the actual sample warms at a twice as much rate as if it's put in just ambient rather than dry ice. So people tend to put dry ice and thinking it's actually helping, but it's actually worse for the sample. In this case, in 1 ml tube, it crosses in 15 seconds TG if you're just putting in dry ice. It's slower if you just leave it on the air. The best potential is just to leave, best solution actually, is just to leave it on the counter and put it in a cryo-wrapping. It is counterintuitive because most people think that dry ice will help, but actually it's not actually helping. So what are we looking for? We're looking for cell viability and cell recovery. And we ran an experiment and we have the data on this. It shows that if you look at a pre-freeze, which is the purple line, and you just keep it for long term at -190 versus freezing and thawing 20 times exposures cycled in and out. So these are the different options. And you see that if you freeze it and you don't, before pre-freezing, you see the result is 100%. After you freeze it at 190, but keeping it at control temperature, the reviability and recovery is quite high. But as soon as you see it cycling in and out of -110, which is above the TG temperature, the recovery dramatically drops, and you also get a lower viability of the cells. So common sample management workflow challenges. So one is lack of visibility. We have multiple sites, different floors, freezers. We have different locations of samples. Data is either on Excel or someone writing it down. Inefficiencies, there's no SOPs in place. You get a sample, how do you track it? How do you log it? And so forth. Storing challenges, like I mentioned, you have multiple sites, different areas. You have some automatic, some manual freezers. And then again, traceability and reporting. So who accessed that sample? Who took it out? Who put it back in? So there's a lack of traceability in regards to a sample. Imagine running a test, the cell viability 5, 6 years down the road, not knowing who accessed this specific sample. So, like I mentioned, human error in manual entry. So I typically walked into many labs, and I find that the Excel seems to be, or even handwritten documents. So there's missing data, or there's duplicate data, or typographic mistakes, identification. In this case, this is laser etched, but some people would put stickers, and then the stickers would fall off. And then this provides you inefficient tracking methods using spreadsheets, handwritten logs, and difficulty in label scanning. So if you do maybe like a barcode system that you have, maybe it's inconsistent, maybe it peels off. So these are typical challenges with samples. So in this case, I give an example of a 2D barcode, and these are typically at the bottom of the tube. These are ones we would recommend. The unique 1D for lifelong tracking of samples. The using a data matrix is globally recognized, so you can go from multiple manufacturers. You don't have to stick to one manufacturer. It's compact, allows you unique 1D to etch at the bottom. So etching is quite key. This is laser etched, so there's no sticky tape, and they're harder to damage, and they're harder to lose. So error correction function ensures no misreads. So in case you have it, you have the scanner with it. A true temperature, all two temperature to decodes work well. In some cases, you do have some icing happening, but the new scanners today, they have prior preservation, so they'll be able to read through the icing that happens from the surfaces. Some of them, even with up to 30% damage, they're able to read the code on the bottom of the prior tubes. So this is a schematics of typically what a biobank or a biorepository would look like. You've got, in this case, you've got your cryotubes. They're all stored in these cryo racks. We can either have cryo racks or SPS racks. You've got your scanners. They're all feeding to a LIMS system. The LIMS system is also communicating with your cryo storage systems and your -80 ultra low temperature storage. It could be manual, it could be automated. It's up to you. And of course, this will be reported for you. So you'll be able to give a report on all the traceability of the samples as it comes in and out of the storage. However, to do this, you need to be digitizing your workflow. This will allow you the traceability. So you need to do the various parameters. And we walked into many different labs, and some of them are using ULTs, and they're not keen on moving to automation. That's perfectly fine. But the starting step would be to have traceable sample containers and digitizing. So you can trace the samples and the workflow. So the first step I would always say is automate registration via readers. First you do is you get those readers, barcode readers, such as this. That would be a good start. Second step would be to get the cryo tube, so different types of tubes and barcoding. So then you can do real-time sample tracking. You can automate sample selection using digital picks. You can have a LIMS software so you can pick your samples digitally, and then you go collect them, and you can trace to make sure you've got the right sample. This creates an audit trail and provides you with the meets compliance, whether you're using ISPR, best practice, or ISO standards. This is an example of a software called Freezer Pro. There's many in the market at the moment. This breaks down, for example, different freezers, different floors, different groups, and it can even tell you what type of sample in the rack is. If you remove it, you return it, exactly where locations are. So it tracks multiple locations, multiple types of platforms, storage platforms, and samples. I think anyone who's done any work in a lab will recognize this, sitting on the ground trying to find your sample somewhere, exposing all these, we call them innocent samples, to pull out 2 or 3 different tubes. If you saw the graph earlier with recovery and viability, it's more than 15 seconds sitting out there, and it's exposing itself to temperatures above TG. This is something you kind of want to try and avoid. So this is a typical workflow, but it shows you how often innocent samples are exposed. So you may have transported the samples from a different hospital, different location. You move them, you place them into a cryo tank, period of time when transfer them into cryo tank. Then you're accessing, got over 1,000 samples in here. You're accessing them all, trying to get 1 or 2 samples or whatever. And you transfer on your bench, you work on it, and then finally you transport it to any other location sugar. So as you can see, there's multiple points of in your workflow where your innocent samples can be exposed. This, however, is an option where it's a reflection of what you can do when you have an automation and logging in place. So this is an automated platform, an example of one. The sample remains below this is the TG, so it stays below. Even if you're accessing other samples, it's automated, comes up, turns a rack out, so it keeps the rest of the innocent samples below 130. And you transfer the cryotube into a cryopod. We have one on the bench to show it to you. Those cryopods are designed to hold cryo racks and cryo bags as well. So we transfer the sample to another lab, and then we can refreeze it, or we can even use it to another lab. The whole period of time, the sample is stored between automation, cryopod, back to automation storage. It stays below minus 135. And these are nitrogen cooled, so you just pour a bit of nitrogen and it stays for 3-4 hours, so you can take it around the whole facility. So this is what an automated cryo system looks like. You probably recognize the bottom part, which is like the manual ones, but the difference here is it rotates automatically. And this allows you to keep the innocent samples away from temperatures above minus 30. So the benefits are sample protection, safety, and accessibility. The automation provides you traceability. So you pick the sample that you want. It'll give you the full
traceability of the sample, where it's going, who had access to it. So you have a real-time inventory control, cold chain management, and superior user interface because it's quite intuitive to use it. You can have cryo boxes and you can have cryo bags, cassettes for cryo bags, and you can access them within less than 60 seconds. They're CFR compliant, LIMS connectivity, and you can get IQ, OQ. So there's a lot of benefits of moving to automation if your volume is requiring it. Here's a range of types of automation you can have, different cryo stores depending on capacity. Many suppliers have these, so it just gives you an idea. You can store from 8,000 to 63,000 files. The cryopod, which I mentioned earlier, is nitrogen cooled. It's portable. You can come take a look at it. It maintains temperature below -50 degrees once liquid nitrogen is used, and you keep it over 3 hours so you can hold that temperature. So very convenient for within lab transport. So if you are working with other samples where you don't require cryo, but you also require -80, for example, or -20, for example, DNA, RNA, and extracted solution, not just tissue. There's all types of platforms available to you, and you've probably seen Al Jalila Hospital, maybe Abu Dhabi Biobank now, Saudi Biobank. They're starting to have automation at -80 degrees. These are entire rooms automation. They can store up to 3, 4, 5, 6 million different samples. And at different temperatures between -80 all the way down to -190. The -190 is all cryo, but the -80 is all cooled through compressor systems. This is what it would look like. This is a room, depending on the size of the volume of samples you require. You would have down here the sample input output. This is picture 3, which show you the individual sample picking. So you pick within a -20 section. These are stored at -70, -80 or -70. Sorry, -20, depending on what kind of configuration you require. The compressors are stored outside, so there was backup redundancies in place. The interface is right here, so you can program the type of sample, which samples you want, and automatically it will pick it on an individual level. The cryo systems, they pick on a rack level. These pick on an individual tube level. Now, it's not particularly only tubes. This is just an illustration of what other type of samples you can store. So we can go anywhere from cryovials, which we just showed earlier, but you can go down to syringes, bags, cryo bags. So you can go to Eppendorf tubes, Falcon tubes, urine cups, plates. So there's all types of samples being stored. So just to reillustrate a typical biobank or biorepository, you have various steps in the workflow. You've got your sample collection, barcode assigned. It could be blood, urine, tissue, saliva, or any of all that. You collect them, you label them. Serious talking to me right now. Then you transport the sample, you code them into the system, the barcode readers. I think it's talking by itself. So sample processing, quality control. So we've got aliquoting system, liquid handlers, depending what you're using, blood fractionation systems, decappers, cappers. All that processing happens in this stage. Then you sample storage cataloging, put it into the systems, the LIMS systems, and your storage systems. Then you can retrieve them, and then you can dispose them or use them for further research. But all of this is data logged the whole way, so you're tracking them, and you're minimizing exposure to samples, to temperatures that you don't wish to expose. So the key points here is collection labeling. It's assigning unique barcodes and registering to a LIMS system. Transport and accessation, verifying barcodes on receipt, processing and QC, so any aliquoting, centrifuging, fractionation that's required. Storage cataloging, they should be going hand in hand. So either you have ultra-low freezers or you have cryo systems or automation. Retrieving them again, make sure you're retrieving the right samples. You need to have like a handheld reader, so you make sure they got the right samples. You'd scan that, and some softwares will give you an alert if you grab the wrong sample. But only that's possible if you've got a barcode efficient traceable access system. And of course, you've got a disposal and archiving system that's ethical disposal of the sample, and long-term preservation as well. So final slides here. Sample quality defines discovery. Integrity of every tube underpins diagnostic research and therapy. Standards matter. There are standards available from ISPER and ISO 20387. They're not just guidelines, foundation of trust, reproducibility, and collaboration. Technology today enables compliance. Liquid nitrogen storage, we discussed it earlier. Liquid nitrogen storage can hold temperatures up to 2 to 3 weeks. And you've heard stories of freezers breaking down and so forth that would impact the sample. Digital tracking, automation, eliminate risks, improve reproducibility, and future proof of your biobank repository. Preparedness is critical, so SOPs in place, redundancy, so samples are stored in multiple locations or in multiple files, disaster planning, and so on and so forth. Your vision is that by embedding best practices now, the UAE and the rest of the region can build biobanking ecosystems are globally interoperable, compliant, and ready for tomorrow's science. Just to finish off, let's work together to make sample quality, regulatory compliance, and user safety the cornerstone of sample management in the region. Thank you. And if you'd like to discuss this more, we're at booth A3.
That was an excellent presentation, Mr. Victor. I believe we all appreciated both the content and the way it was presented. So I would like to call him to give a top-notch presentation from our side. Our next speaker is Dr. Khalid Al-Bayani from Oman. I am passing him the stage to deliver the speech on an interesting topic, artificial intelligence, AI for early cancer detection and screening.
So I oncologist. So I'm happy to be medical oncologist and go easier than the language of pathologist when it comes to that. Because today I'm presenting artificial intelligence and scale. So metastatic cancer is a dreaded reality. It's a dreaded reality for patients, for families, for doctors, because metastatic cancer lead to patient death. So early detection is of paramount importance because we know that if we diagnose cancer early, patients do better. So here I'm presenting the breast cancer survival by stage. So you see, if you diagnose patients who are stage 1 or stage 2, they do far better than patients who are diagnosed as stage 3 or stage 4. So what we're trying to diagnose them early so that they can survive. We look at the history of screening and we see that the screening is not something recent. The screening has started in the 60s when Finland, Sweden, and UK started doing pap smears for cervical cancer. In the 80s and early 90s, screening for breast cancer with mammogram was started in Sweden, UK, Netherlands, and Finland. And US task force started recommending breast, cervical, and colon screening. In 2003, the European Union Council recommended doing colonoscopy or colon cancer screening. In 2013, US Task Force recommended doing low-dose CT scan for high-risk lung cancer. And in 2020s, nowadays, there is significant work in exploring detecting cancer early using liquid biopsy by drawing blood and looking for circulating tumor DNA or methylated DNA or other techniques. None of these have been approved, but there's significant work is being done. So this is a busy slide, but the bottom line that the current screening guidelines recommend screening for breast cancer using mammogram. Depending on what guideline you use, the age may differ. And there is around 20% relative reduction in breast cancer mortality. Cervical cancer also is recommended to be screened you using pap smear cytology or HPV. Again, the WHO, US Task Force, and European Council all recommend screening for cervical cancer. Colorectal cancer, on the other hand, also has been recommended by the three guidelines with 28% mortality reduction for early detection. When it comes to lung cancer, there is some disagreement because the WHO and US Task Force recommended. Europeans, they say, maybe pilot or evaluate. For prostate cancer, there is no universal consensus about the screening for prostate cancer. So now we look at the cancer epidemiology to see what cancers that need to be screened. And when you look at the top 10 cancers in the world, you see that lung cancer is number one, breast, colorectal, prostate, stomach, liver, thyroid, cervix, bladder, and non-Hodgkin. There is regional variation between regions, but this is the global kind of top 10. But the interesting thing is, so although breast cancer is number two in terms of incidence, we see that the mortality of breast cancer comes number three. So although the number of cases is high, but less patients are dying. And less patients are dying is multifactorial, of course, because treatment has improved significantly and we're doing a better job at treating them, but also because we screen them, we diagnose them early, and they do better. Look at something like stomach cancer. It is number five, but it is as incidence, but it is number three in killing patients. Look at colorectal. It's number three in incidence, but it is number two as a killer. So some cancers, because we diagnose them late, they end up killing patients. So diagnosing early will save lives. Now, what cancers to screen and what test we do? So the WHO came with criteria, they call them the 10 principles by Wilson and Jogner in 1968. And these principles were the framework that all screening programs were developed. And so what it says that the health problem should be important. So high burden disease or high mortality, the natural history of the cancer needs to be understood. There should be a pre-symptomatic phase where you can diagnose them. There should be a suitable test or examination that can be done. And there should be an acceptable, the test should be acceptable. And the treatment should also be available to treat these patients. And the treatment should be acceptable. And the facilities to do this diagnosis and treatment should be present. And it should be economically balanced. And the case finding should be an evolution, always development, quality improvement to improve the process. So these 10 principles guided the screening programs throughout the years. Now, many other principles were suggested by many other researchers and entities. And so these principles were updated in 2018. And so now they divide them. They say, okay, let's focus on disease, test, and program. And so the disease, the incidence and mortality, the preclinical phase, and the target population, they stayed. The intervention, the result in the test performance should be accurate, safe, and acceptable. Result should be easily interpretable, and you should have a clear cutoff. And the post-test options in terms of confirming diagnosis or treatment should be available. When it comes to the system, they added 3 more principles. And so the infrastructure should be available. It should be integrated in the health system. should be acceptable and ethical, and the benefit versus harm should be calculated and cost effective and resource available. The quality management, always continuous development and improvement. So the updated screening principles focused on the system. And so now when we discuss screening, they don't say screening, they say screening programs. They don't say screening test because the program is very important because sometimes the test is fantastic, but the program does not exist. So now we come to the artificial intelligence in medicine. So I thought before we talk about artificial intelligence and its role in screening, let's look at its history in medicine. Because I think now there is a lot of hype about artificial intelligence, but it is interesting to look back at the history. So artificial intelligence as a terminology in medicine and in the literature goes back to the 1950s. So artificial intelligence is not something new. The way artificial intelligence presented in that time was the simple logic. If this, then that. So very simple algorithmic artificial intelligence or very rigid rules. But this was the start of artificial intelligence. Then later on, in the 1980s and 90s, we started hearing about machine learning. So the machine learning or ML, and this is what is present in the literature as well, we started using things like decision trees, KNNs, and other things. And these got incorporated in ECG machines, in early computerized aided diagnostic tools. In the early 2000s, with electronic health records and the availability of big data, we started now incorporating machine learning using big data to develop algorithms, risk stratifications, and also we started using it in radiology, computer-aided diagnosis. In 2010, we started having a new terminology called deep learning. So deep learning and characterized by neural networks or convoluted neural network, or what they call it computer vision, which is the ability of the machine to read an image and convert it into a diagnosis. And so in 2018, FDA approved the first autonomous device to diagnose diabetic retinopathy. So now the machine is able to look and tell the diagnosis. So this is the deep learning part. The machine is able to learn and give. Now, in the 2020s, with the current hype of artificial intelligence, there is further advancement in deep learning. And so now we're discussing transformers, large language models, generative AI, and multi-omic data, which is very important in oncology and medicine, because now the machine is able to take radiology images, histopathology slides, can look at molecular biology reports, can take clinical data, epidemiological data, take all of this at once and make impressions, make predictions. So this is going to be the transformation when it comes to medicine. So to look what people are doing right now when it comes to clinical trials for screening and utilizing artificial intelligence, I searched clinicaltrials.gov to see what is happening right now. And so you see there are multiple clinical trials or studies incorporating artificial intelligence in screening tests. So multiple in breast, colon, cervical, GI, melanoma, lung, and prostate. Multiple studies ongoing. Some of them completed, but not yet published. Others are still ongoing. Then I looked, okay, what are the approved AI tools right now, which are already approved? And you see that FDA approved many solutions, but here I'm just highlighting the AI solutions which are related to screening, but not all the AI approved solutions. So the AI approved solutions for screening, there were multiple ones in breast and mostly in mammogram reading, in colon, incorporating it with colonoscopy, cervix with the digital cytology reading, in line with low-dose CT scan, in skin for diagnosis of melanoma, and in prostate. Then I said, okay, these many solutions are already FDA approved. Are they backed up by clinical trials? I'm a medical oncologist. I treat based on level 1 evidence, clinical trials. And interestingly enough, lots of solutions which are approved by FDA for screening or otherwise are not backed by clinical trials. because they are considered softwares, they are mostly compared to retrospective data. So they compare the new solution to a performance of a previous software, and they can get the approval. Anyways, for the sake of a medical oncologist mind, I try to look for the large prospective clinical trials when available. So here I highlight some clinical trials which are available. So here, this is the MASAI study, which is a large randomized controlled trial looking at the incorporation of artificial intelligence in reading mammogram. And so this is randomized 1-to-1, either the standard double reading by two radiologists compared to artificial intelligence and radiologist reading. So it was not artificial intelligence reading, but artificial intelligence plus the radiologist or the radiologist reading. So they compared between the performance of the two. And what we get from this study, the detection rate increased by 29%. The invasive cancer diagnosis was elevated by 24%. In situ was increased by 51%. Recalls not very different between the two arms, and the positive predictive value of recall. So if you get recalled and you get biopsy and you get diagnosis of cancer, it was higher with artificial intelligence utilization. So they were not forced calls. Another study which is done in Germany, which was real world study, they incorporated artificial intelligence in their mammogram screening already. This is a huge study published in Nature Medicine in 2025. And then you can look at the numbers of patients who got this. 202,000 patients in the standard arm and 260,000 patients in the AI supported. Again, what we find out of this study, 17% increase in cancer detection rate. And there was recall rate in this study was less compared to the radiology reading. The positive predictive value for recall was higher in the AI supported. So if you get called and your mammogram was read by artificial intelligence, you're more likely to have a positive biopsy. Here I move to colon. Now, here is inclusion of artificial intelligence in real life, real time. So the endoscopist is doing endoscopy. At the same time, the machine is telling him there is a polyp, there is adenoma. So they tell him real time. They pinpoint in the monitor what is happening. So this is a multi-center open label parallel pragmatic randomized controlled trial in the UK. It was done in 10 NHS trust in England in 12 hospitals. So the interesting part, not only screening, but they also included symptomatic patients, but 60% were actually screening. And what they found in this study, 8.3% absolute increase in adenoma detection rate, and no safety signals in this study. And another Korean study, they incorporated artificial intelligence in the colonoscopy. And in this study, they found there is the polyp detection rate 10% increase. Adenoma detection rate was 7% increase. The likelihood in this Korean study, the likelihood of getting biopsy was actually interestingly less because the machine was able to tell the endoscopist there is no need to do a biopsy for this patient because it's a low risk. Now we move on to melanoma. So in melanoma study, this is a prospective study that looked at handheld AI powered device to look at images and say, this is melanoma or this is not melanoma. And so this is not a randomized study, but a prospective study and got FDA approval with this study. So the sensitivity of saying there is melanoma was 95% with a negative predictive value of 98%. So if this device says it is normal, you're less likely to have melanoma. The challenges with AI in breast cancer, as an example, because I treat a lot of breast cancer, is when you look at technology and infrastructure, you need a lot of data centers, you need cybersecurity, you need privacy protection of all this data, reproducibility or ability to run the same model, same machine in different demographics, different populations. This is something is being challenged because of the artificial intelligence background, which I'll come to in a minute. The evidence quality, majority of FDA approved software are actually not backed up by randomized controlled trial. They are backed by retrospective data, small retrospective data. Societal issues, which is serious. Now, doctors, we as doctors are scared from the machine. The machine is infringing in the planet of pathologists. The machine is infringing in the planet of radiologists. So we as doctors, again, they will infringe in the oncologist planet as well. But we are worried as doctors that with the machine take our place, and that's a serious problem. Trust and acceptance. Given that we do not understand what the machine is doing, it's a black box for us. We don't understand. So we have kind of less trust on this, what is the machine doing, and I cannot explain it. Ethics. The background of these models is training on data sets that we don't comprehend fully. What were the data sets used in training them? Legal issues. If the machine makes an error, who takes the legal responsibility for the error? Is it the machine or the doctor? And after rollout, like, okay, there are new things happening. Who would retrain the machine? When will you retrain the machine? Here I touch on a very sensitive topic when it comes to AI: diversity, inclusivity, and traceability. This is a documentary called Coded Bias, which it is of interest if you're interested in artificial intelligence because it highlights important points for diversity. First, I said, okay, let's look at the epidemiology of cancer. And I arbitrarily divided the Global Can 2022 data into North America, Europe, and Oceania, and then Asia, Africa, and South America. Arbitrarily, I apologize, not scientific. Then I said, okay, for Europe, North America, and Oceania, is there a difference in the epidemiology of cancer? Are we interested in the same cancers or are we interested in different cancers? And interestingly enough, you find in this graph that gastric cancer, liver cancer, and thyroid cancer are cancers that are not appearing in the horizon of Europe, North America, and Oceania. There are serious problems in other countries. So prioritizing these cancers for screening and developing AI models may be of less interest to them, more interest to others. Then I looked at what was published in this, and I use again breast cancer. I'm a breast medical oncologist. This is a fantastic systematic review, which was published in 2025. They looked at all the data sets used in training mammogram models, and what it showed. FDA approved 39 mammography AI tools as of 2024. When they look at data sets used, only 45% reported age, only 30% reported sex or gender, only 13% reported race, and 2% reported socioeconomic status. When the authors tried to contact the owners of the datasets, only 28 out of 254 datasets were actually accessible. So it's a black box. I don't know what was used to train the machine. So, and most datasets are actually North American, European, or East Asia, less so from Africa and from our area. So the future directions, I think we need to work on the reproducibility and generalizability, trust and transparency, infrastructure needs, governance and monitoring, ethical and legal frameworks, the things that are challenges, and diversity and inclusion. We need to make sure that diverse data sets representing different demographics is being used. So now looking back at the 12 principles, the WHO 12 principles, let's look where AI can help. And so when we look at that, the AI cannot change the epidemiology, but it can make us understand epidemiology better. The machine cannot change the natural history, but it can give good insights about the natural history by this availability of big data. Target population, the machine can now incorporate all these multiomics and say, this population, these people are at risk, you need to screen them. So instead of doing mass population based, you can do targeted screening. Test performance, we already looked at clinical trials, and we know that the test can perform better with incorporating AI. And the result interpretation, oh my goodness, you can just ask the machine to give you the report, and the report is ready in 2 seconds, and probably better than humans. When you look at post-test, the machine can propagate what you need to do after the test. So it can tell you, you need to triage, you need to retest, it can propagate further things after. When you look at infrastructure, the work in the Sweden study in mammography, it showed that there is 40% reduction in workload on radiologists reading mammogram. So less work, less workload, they can do more readings for more tests. You can integrate it in the health system easily. And when there are less callback, when you call back patients less, or when you call them for serious problem rather than having false alarm, it increases the acceptability of these tests. And we look at benefits versus harm. I think we understand better. We do less overdiagnosis. We hope so. And economic evaluation, if we do for higher targeted population, we do less testing. And if we have our tests do perform better, we perform less biopsies. We probably can target less number of patients. So cost saving. And the quality management, the AI can always propagate quality improvement and can auto do audits. Here I gave examples, which I think for the sake of time, maybe I will just take pancreatic cancer. Obviously, pancreatic cancer has no approved screening program. One of the issues with pancreatic cancer, we don't understand the natural history of it. We don't know when that transition happens between being early versus now it's advanced. And so what AI can do, it can help us understand natural history. It can enrich the target population by doing those comprehensive analyses. It can facilitate suitable tests by improving the sensitivity and specificity. So although it does not change what is in the ground, but it can make us understand it better. I will skip this slide because already I presented, but this is quoted from Hunter's et al. In Cancers 2022. So the take-home message that screening can save lives for major cancers. AI expands capacity, quality, and efficiency, and the equity, governance, and monitoring are essential. Thank you. If any question.
Now we are welcome for the question. Any? So that was a fascinating session. It really shows us how the technology and medicine are coming together to transform the patient care. Thank you, Dr. Khalid, again for sharing such an exciting glimpse into the future. Now it's the time for token of participation on behalf of community. Our next keynote speaker is Mr. Omar Ali from UK. I'm passing him the stage to deliver the speech on innovative contracting with new medicines. Please welcome.
Thank you. Can I get my slides up, please? Hello, welcome. Is this one?
Yeah.
Thank you. Hello. Sorry. Hi. So, welcome. Thank you for having me. What I've decided to put together is my PhD thesis area. It's around oncology medicines, and it's a specific notion how we are the challenges facing healthcare governments for the new innovative technologies and medicines for cancer. And I'm a former pharmacist. I worked healthcare hospitals. I then was an advisor to the UK government and got heavily involved with drug negotiation, pricing. And that's where I kind of fell in love with this innovative contracting idea. And I think you're going to find it fascinating if you haven't come across it yet. But the move to value-based healthcare is definitely a global phenomenon. And we're now seeing it with medicines. Okay. So if you ever come to London or UK, come and have a look and find us. We're going through an interesting, I think, evolution with healthcare at the moment as we're trying to embrace new technologies. But the budgets are becoming astounding. And the healthcare costs, not just in UK, Europe, but are growing phenomenally. And I think that if you're a drug company trying to launch a new cure for a medicine, it's probably a challenging time because they're charging very high prices. And many healthcare governments are going into very strong negotiations. And we've seen, for example, in the US, what the new president is doing, talking about drug pricing, tariffs, and creating actually quite an interesting international wave of how we're looking at medicine pricing. In fact, he's saying that in the US, he wants to bring the price down and he wants other countries to pay more. So it's an interesting political inflection when other countries already feel they're paying too much. So how do we get the drugs we want for our patients at an affordable methodology? Before I do that, I want to just share an interesting concept with you. I'm going to go blank, okay? And there's a story I'm going to share about oncology drug I negotiated when I was a payer. If you purchase something that is expensive and it doesn't work, tell me, what do you feel you want to do? Let's take like iPhone or something like this. Say you purchase brand new, spend a lot of money, and it doesn't work. It doesn't give the results. What you want to return it? Yeah, exchange or give your money back. Exactly. If you buy a car, often they come with a warranty. Yes, from reputable dealers. If something goes wrong, they fix it. If it doesn't work, give your money back. If you go to your doctor and they prescribe you a drug and it doesn't work, do you think you can go and get your money back? Everyone's saying no. Why not?
Because you don't know if it's not working because it's suitable for you or just.
So there could be many reasons.
Yes.
But this is also true for the car and the phone.
In addition to the drug causes, there are also patient causes. How the
Yes.
patient is compliance.
Okay, what if I put my phone in the microwave? What if I drop it many times? What if I don't look after my car properly? So there's always going to be confounding variables. If I tell you now, we are contracting with drug companies. If it doesn't work, they are giving the money back. It started, but it's very difficult for exactly the reasons you said. If you go to a pharmacy and you buy a painkiller and you say, I'm still in pain, they don't care. Well, maybe they care, but they certainly will not take the medicine back because you've eaten it already. And if it didn't work, that's just life, right? They'll say. Statistic. Sometimes it works, sometimes it doesn't. So why this new contracting? This is my PhD. And let me tell you, it's happening, but it's not easy to find out where it's happening. But it's happening. Why is it happening? I've found 3 key drivers. Number 1, the rising costs are becoming insatiably impossible, both for patients in private markets and for governments in public health or copay markets. Why do drugs become so expensive? Well, some of it is the pricing and some of it is the insurance model. if you know the US system, the drug company doesn't get a very good net price, but there are many people in the middle who are taking. So if the drug is $2,000, the company is maybe getting $500. Other organizations are taking. This is a drug called Zolgensma. Has anyone heard about it? It's for SMA, rare disease. Young children can become disabled and they die early. 8 million dirhams to treat one baby. I'm going to ask the question, is this going to be sustainable? And there's another question. If you have a drug that costs 8 million dirhams, who's going to pay for it? You're going to pay for it? The government going to fund this? Or what is the point in having a treatment that is like a cure, but nobody can get it? What is the purpose of that? This means we have done R&D and budgeted lots of research, excellent science. AI is not going to help us here because no one can afford it. I like this sentence. This was in Gulf News. What is the value of human life? Yeah, because I think if it was your loved one or child or nephew or niece, you would just say the government should just pay. Don't put a price on a life. Yet we know with healthcare, cost effectiveness is very important. And this means sometimes we are putting a price on the life or the disease or what it is. Firstly, it's a global problem. So although I gave some UAE examples, everywhere is struggling from what I've seen. Different countries are struggling. We also have the situation, there is global unrest. We have a Ukraine-Russia situation. We have ongoing Middle East. These things never help for stability and finances. And if there's unstable finances, it means governments will struggle. The first is a framework. So can you just make up a price for a medicine? How much profit is allowed? What is the regulation behind this? And so many countries will try and do some kind of framework. HTA. Like we know, like we do a lot of work with some of the Saudi, King Faisal, King Abdullah. There's good HTA there, like what NICE do. Cost effectiveness. We don't just pay any price for any medicine. There is a framework so that it is priced responsibly and providing the value. The second is affordability. Sometimes the cost of the drug is not so much. Maybe GLP-1 for obesity. But if half the population is overweight, this is a big budget because everyone wants the drug. So that affordability is sometimes different. And the third one is uncertainty. I looked at the top 10 most expensive medicines to treat one patient. And over the last, I would say, 6 years, we have seen it go from breaching $1 million to $3.5 million. And the latest one was 4.2, 4.5. So nearly $5 million to treat one person. I don't think this is going to be sustainable. And there's going to be arguments. And often the drug companies will say, the patients need the treatment, you should pay. The government will say, you need to price responsibly. And there's often a stalemate, like any negotiation, where it gets stuck. So I asked this first question is, will the bubble burst on these new therapies? Because we all want the latest treatment. You might have seen on LinkedIn sometime, this is showing cell and gene therapies coming. In the next 5 to 7 years, each one of these dots represents a cancer or rare disease. That treatment we think will cost more than 1 million. So when physicians and patients see this, they're excited. But I can tell you, when payers and government officials see this, they're worried. They're worried. Because if the drug costs $1 million for everyone in the room, I have run out of money. And rare condition is not that rare. Cancer is becoming very common, right? Globally, we are seeing. Statistically, in this room, we will have it. Statistically, probably all of us know somebody, a loved one, or care for someone who's got it or had it. So it's not rare, uncommon, it's common now. Why I say uncertainty? This is an interesting element. We are in a phase now where people want the medicines very quickly. There's like FDA rapid approval. If a patient is dying, they don't want to wait 10 years for a clinical trial. So the clinical trials are happening very quick, maybe 18 months, 2 years, and then quickly they want to launch the drug, make money, profit, and the patient don't want to wait. So we are seeing many drugs come to market with immature data. Not 3, 4, 5-year evidence, sometimes 18 months, 2 years, difficult to establish, really. Is it a cure? How effective is it? How well is it going to work in my population? Can't tell. Too early to tell. Too early to price. Too early to price. So there's a tension in the system. We want the drugs quickly. We don't want to wait. Everything is getting fast track approval. How do we price with the immature data? This is one story I have to share because this is how I fell in love with the innovative contracting. I was in the government at the time, having all sorts of price negotiations of the evidence. And this company came with myeloma drug. It was very innovative, no doubt. Had very good data, but not perfect. The problem was their price was too high. Another problem was they wanted to treat the whole population. We had a big argument with them. And we said to them, look, you're asking too much money and your evidence is not strong for first line. The clinical data was a heterogeneous mix, first line, second line, multiple line. So your primary endpoint was composite. We fell into a stalemate. If anyone plays chess, you know the stalemate. No one's moving. And while no one's moving, no one's getting the treatment. And there is in the news, this is a new drug for myeloma. The patient is demanding, but the government is saying, we're not paying yet. We're stuck. Not good. It's not good. The company are not wanting to reduce the price. The government are not wanting to increase. Stalemate. This happens very often. And it creates a big tension. Nobody moved. And something happened in this negotiation I was involved, which was a bit magical. And it was the first time I was involved with an outcome-based innovative contract. It was clear that they were not going to move on the price, and it was clear they did not move on the population. The company also realized the government were being strong and nice. They're very harsh. There's no copay in the UK. Patients don't pay anything. It's completely free. So no point asking them to pay. Doesn't exist. The company did something I had never seen before, although I am told now it wasn't new. They said, here is the situation. We are demanding the high price. We demand the first-line population. But, if the drug does not cure the cancer after 4 cycles, you get your money back. Wow. Like, this was at the time revolutionary, but now I'm telling you, is common. Companies are doing this now with governments. And my whole PhD is following the globe to see which companies are doing it, how are they doing it, and we have a whole consulting team now helping other companies to do it. So what types of innovative contract is there? And it's not just a money back guarantee. There's financial contracts that are innovative. There are warranties and money back guarantees. There are outcomes based and there are service based, digital therapeutics and wraparound support. So the innovative contracting is spreading both in its nomenclature as well as across the globe. We now have a research team that follows who is doing the innovative contracts. When I mean innovative, I mean price volume, that's standard. Innovative means like something they're giving money back guarantee, or they're supporting on the efficacy, or there's some measurement of success. Like if the phone doesn't work, you get your money back. But as you can imagine, and I think some people said here today, there could be many reasons why the drug doesn't work. And it may be nothing to do with the drug, it could be to do with the patient. These are the contracts that we are now writing to build that in to these contracts. Because a money back guarantee sounds simple, but it's not. It's not. How you even define a remission will vary with each cancer. And how long will that remission be? And how much money will they give back? But it's growing and spreading. And the reason for this, because the drug prices are so high, they will not just buy now on a simple discount. And the companies, if they're selling a drug for 8 million dirham, the discount isn't really helping. It's still nearly 8 million dirham. If I'm spending 8 million dirham, I want a guarantee, for sure. For sure. Because what if that drug doesn't work? I definitely need to have my money back. And I tell you, Zolgensma, there isn't a country that haven't got some guarantee in place because the price is so high. A couple of quick cases. Xalkori in the US. This is for lung cancer. They have done a 20,000, this is $20,000 for 1 month. The patient is paying a lot of money. And what they have done is given what they call a warranty. If the patient doesn't have at least the minimum PFS guarantee, then the patient can claim their money back with a physician letter to say that within 3 months of treatment, no good. And the contract says if they stop it any time within the first 3 months, they don't have to pay. They don't have to pay. Because why would they stop it? It means something has gone wrong. If it's gone wrong, the company said we won't charge. This is Novartis, CAR T therapy. This is for CAR T is coming now, particularly that we're seeing nearly curative-like results for the blood cancers, not the solid tumor, the blood cancers. When I say curative, what I mean is like instead of 80% death, more like 80% remission. Like it just turn it upside down. But these are minimum $500,000 for one person. All of the European countries, none of them are paying like traditional medicine. All of them have a contract which is based upon the blood results. If the patient is in remission year 1, year 2, year 3, year 4, we pay. Any patient that the cancer comes back, we don't pay. And the amount we pay is proportional to the duration of remission. Does that make sense? Calibrated. So if you have at least 5 years, good, we pay. If you have 1 year, mostly we don't. If you have maybe 2 or 3 years, we agree of half payment. So we're now paying for the outcome, not for the drug. It's not about the drug, it's about the outcome. And for the lymphomas, they're using minimal residual disease and other endpoints, agreeing with them. This was in China. China is very unusual. They do not traditionally do this contract, but for breast cancer, there was a pay for performance, and Pfizer did a PFS guarantee 4 months. 4 months. So we are seeing that this value-based healthcare is now spreading to medicines, not just healthcare. And I think that we are also seeing UAE, there are some contracts, a lot of them are confidential, but right now where you are in the Gulf states, this is growing because companies are getting more experience and they're testing with other markets. And governments are getting more experience from learning from other governments who are doing it. So the idea that if the drug doesn't work, you get your money back, although it sounds intuitive but difficult, we are overcoming it. Why? To give access to patients. I think without this, we would still have negotiation in stalemate, where the drug is on the shelf, but nobody can have access to it. Here's an interesting cancer question. You're all healthcare professionals, right? Think of yourself like if a patient or a loved one. 2 new drugs have come out, both of them for the same tumor or disease, doesn't matter. Drug A, this will add 1 year extra OS. OS gain 1 year versus standard care. However, only 2 months PFS. So what does this mean? I'm giving you an extra year of life, but only 2 months is cancer clear, 10 months ridden. Metastases, pain, suffering. But the OS is 1 year. So I'm adding an extra year. Drug B, same tumor. Have a look. OS is only 6 months. So you don't live as long, but you live better. PFS 5 months. So what does this mean? You only get 6 months extra life, but 5 months is good. 5 months is good. Same price. So tell me, put your hands up, you want drug A? Nobody? When you read your clinical trials, do you not first go to OS? All of you. It's a gold standard. Right. The patient question, how long have I got? They don't ask, how good have I got, right? How long have I got? Put your hands if you think you prefer drug B. Nobody. Okay, no one, anyone, any drug. So here's the balance. Is it length of life or is it quality of life? This is what we're paying for. It's inevitably a combination, right? And at NICE, when they talk about the quality, and that's what this is about. The quality is a measure of the life year gain, also the quality of the life year gain. There's no point living forever if you are in pain forever. You want good quality and good duration. Most of our cancer drugs do not give us this. They don't. I just want to fast forward this to my epilogue. Sorry. Where's my chairperson? How long have I got here? I'll show you this one and then we'll go. The next time you're looking at a new medicine, this is something we used to do before we walked into the negotiations to give a feel. Sometimes when you try to negotiate with somebody, you try and judge, what position am I in? Am I in a good, strong position? Am I weak position, right? Am I going to have to give a concession? Most people, I think, if you're good, you get that feel before you walk in the room. Okay? When I arrived, by the way, from the UK, I didn't get the room I booked at the hotel. They've been very good, by the way. But I had a negotiation on my hands. I said, hold on a sec. I booked this. And why have I now got this, right? I thought I was in a strong position. But at 2 o'clock in the morning, with the front desk person who's junior, I was in no position. Do you understand? So I realized, I said, Omar, shut up. Don't have this discussion with her. I'm just stressing her out. You need to have this discussion with someone who has a negotiating power, right? So today I had that discussion. It was good. You have to pick how you negotiate with who. So here's a drug treatment, and this is time at the bottom, and here is disease progression. So this graph, as you go higher, the disease gets worse. So let's say you've got some illness, could be anything, type 2, oncology, cancer, neurological, Parkinson's. Suddenly you give somebody a magic pill or magic injection. These different trajectories is what happens afterwards. Okay, what happens afterwards? Look at line A. What's happened in line A? Next thing. Nothing. The line trajectory is the same as before the treatment. Why would I pay for this drug? Yet there are many drugs that come on the market that have a line A. Do you understand? And they still want a good price because that's their job. There are some drugs, look at, say E or F. Not only do they stop disease, they reverse. Unheard of. There's not many drugs that reverse. Asthma help the symptoms, diabetes, insulin is not a cure. You're treating some of the symptoms, maybe some of the complications, but inevitably it catches up, right? All patients with type 1, type 2 at some point will have microvascular disease, retinopathy, cardiovascular, dialysis. Maybe we can slow it down, but we are not curing the patient. So very few cures. So the question is, next time you look at a drug, what is the line you think? How does it sit? And then, from my side, we're asking, is it good value? And our negotiation will be based on what we think the line is. And I would say to you, in general, as a government payer, our line does not match the drug company line. Do you understand? So they will come and say the advertisement is the best drug ever. And we look at this and we look at the data and we say, no, it's not. It's not. You have a wonderful branding, but the evidence doesn't support your messaging. So that's the negotiation. This is my final slide. You know, you can use this when you're at home. I have 3 teenage daughters. They are better at, I have, as a government payer, I have negotiated with the Pfizer, AstraZeneca, you know, the big companies, but my 3 daughters, better than me. And always they win. Do you understand? Always they win. Why? Because they understand the negotiation principle, how to get around me, even though I'm the father. This is like, we call this negotiation dance. So next time your government is negotiating with a company, or next time you're negotiating with one of your children or your husband or your wife or something, access, price, time. Access is the drug company usually want wide access to treat all the patients. The payer usually wants to restrict access to a subgroup of eligible patients. Population criteria, looking at clinical trial, maybe these ones are too young, too old, ECOG status, everything. So we like to restrict based on evidence. The company wants to treat everybody to make the money. The second one is time. They want a good price, they want it now. Sometimes it's our job. If you want a good price, you're going to have to wait. I won't delay because the negotiation is not moving. If you want your drug available today, you're going to have to cut your price. If you want the big population, you're going to have to reduce. If you want a high price, I will restrict the population. It's like a dance between the government and the manufacturer, always going on before the final. Because once the price is negotiated, that's it. Now you guys have to pay for it. Part of the issue we saw, when Trump is causing a lot of headache about the US pricing, why it's too high. And the reason for that is the government do not negotiate with us. Many other countries, like in Europe, were very tough, very tough. We don't care to say no sometimes. If a big company comes, we'll just say no, that's too much. There's not good value. Your data is not good. In Europe, what we say is the price of the drug needs to reflect the value to the patient. Do you understand? In the US, the price of the drug is what the market will bear. What does that mean? As high as possible before somebody, you have squashed them. That's how it works there. In Europe, we are calling this phrase value-based pricing. If it has a good survival data, we'll pay. If you have no data, we are not going to pay. We will just say no. Nowadays, people know the price of everything and the value of nothing. So we won't ever hopefully fall into that trap. Thank you so much. Any questions? Sorry. Sorry, to get my. Thank you. So I started advising as a kid. That's why it's it's like it's out there. It's my so question what I negotiate. I have seen the meeting has let's say what's the market so it's not negotiating so in this negotiation with also negotiation with advice. Because if I cannot transparency, they use to see that so they says they are being seen that most highly. How can you go to the CPDs? CPDs, maybe actually so it's really good negotiations. So negotiating is important. And this will future consequently not say then based on negotiation. But as also market, so the market issue, you're not a fish, so I didn't get about it. Yeah, so thank you so much for your question. So, just leave anything that you proposed. For some time now, the company has never been explicitly already in the profit. So the something to do with what's fair, super fair. I don't will never get that from you. And even when the government tries to interrogate, there's a complexity, which we know true. On the IRA serious negotiation, they're asking the company also cost for it. They're saying very complicated because price in the US R&D is low, you already low in the world. So how do you keep the price in each market? Each market is a good question. How are you able to? And you get charging. I think well, nice is to be developed in sense rather than pay the drug privilege now. We're shifting filters, we're shifting to intelligence. We care because we're going to pay for the outcome. The patients this much this much things we evidence to be shifted over to value-based outcomes. Because outcomes can be available for many issues, not just cancer. So value-based sense is big the results. This makes sense to me. Being a small market in Europe against the small countries, the UK is very small. The risk here is bigger than the markets doing this at the moment. Most of the cost to work France, Germany, Spain, Italy, and the France, in nation independently. So this moves to come together to create us. Belgium, Netherlands, Luxembourg, they individually explore that together. To people in the States parties, to negotiate this, negotiate such a group. It's not 5 countries in the small. The TCC can do it. Now, it's together. Exactly, it is this technology. GCC groups or is a student line, for instance, they are going to student structure there. It's still patients. That's negotiated to say these 7 UAE countries are going to negotiate a lot. State money small, in power, in high price to feed. Together in small amounts, which is very nice. Populism was law. Available stuff so where this can shut up or available. This one actually quite difficult. Because I did it never realized it. Usually question why basic how also it is expensive. I get long way increase I go down so big objection. I need to complicate what about relation. So to say about our government, I'll say in the UK is the tool operations of national religion. That's what I would say. I like whether the conspiracy theory follows the actors basically reversing which the healthy lifestyle is some conspiracy public health company. As soon as you have a disease like hypertension, they always seek companies on meetings and they always sponsor a message, marketing message. Wow, it's response. It's if you want to classic. But we companies maybe know this. People want to harm. Exercise by each careful up. And then these things is okay. But it's natural that states there public scientists talking about public health. Our message always in the UK budget is 5% so it means we will on prevention and it is not based fixing the population sponsored is about developing standing by developing markets is basically it's not being the whole so well that you invest great budgets for banks. Maybe a crazy mark to the extra, agency agro, or essential politician. A target, so you have, let's go there, to the marching everywhere. Right? So we lost them, or it's called some meetings, for example, it's alright, is kind of, and you see one passes down drawing. Because of this, maybe 2 days more than sleeping in public place. There's a finance of the countries that shows. So you see, airport, restaurant, very in public policies. But I know your question, I figured out some. I realized that is very little is taking place in there. So that is an issue. So now, in our first postal presentation, description from Dr. Arya from here. Begin with the next term, and our is clear.
Wonderful. Good afternoon to one and all of you. Myself, I'm Dr. Arya. I'm a pathologist, currently pursuing my fellowship in lab hematology in Christian Medical College, Vellore, that's in Tamil Nadu, India. Okay, so let me take you into the case. I'm going to present this case of transformation of classical Hodgkin's lymphoma to diffuse large B-cell lymphoma. So this is actually quite a rare case where we have these kind of transformations from classical Hodgkin's lymphoma to the diffuse large B-cell lymphoma. Literatures, we do not actually have much literatures that mention about these kind of transformations. The only available ones are usually in the form of a few case reports. The transformation rates is almost like 1%. There are literature that is mentioning about these transformation more maybe in case of nodular lymphocyte predominant Hodgkin's lymphoma rather than classical Hodgkin's lymphoma. So actually the prognosis in fact worsens when there is these kind of transformations. So it is really important to be aware of these transformations so that we can act immediately whenever there is these kind of transformations. So let me move into the case. So there was this 32-year-old female from South India. She had in fact presented with few lymph nodes, cervical lymph nodes and supraclavicular lymph nodes. She did not have any B symptoms though, and the PET scan had actually showed a large mediastinal mass of about 11 centimeters. So an excision biopsy from the cervical lymph node was done. So this was the histomorphology that you can see. There was this large lymph node which had a thickened capsule, and the architecture was quite distorted. And there were these kind of, the atypical lymphoid cells resembling the mononuclear Hodgkin cells, as well as few binuclear Reed-Steinberg cells as well. And the background had, it was a polymorphous background showing the different mature small lymphocytes admixed with plasma cells, histiocytes, neutrophils, and occasional eosinophils. So the immunohistochemistry had shown that it was weak PAX5, and it was positive. So the atypical lymphoid cells were positive with CD15 and CD30. So to summarize the IHC, it was positive for CD15, CD30 with a weak PAX5, and the Epstein-Barr virus in situ hybridization was positive for just scattered lymphocytes, scattered atypical cells, and the MIB1 had highlighted a few atypical large cells, and it was negative for CD3, CD20, and CD45. So a final diagnosis of a classical Hodgkin's lymphoma, nodular sclerosis type, was given to this patient. So the patient went ahead with 6 cycles of chemotherapy with adriamycin, bleomycin, vincristine, and daunorubicin. 20 fractions of, apart from that, she underwent radiotherapy with 20 fractions of radiotherapy. And then when a PET scan was taken, it actually showed a residual disease. And a PET scan at 7 months, in fact, showed disease progression. So, seeing this PET scan, again, a repeat biopsy of the cervical lymph node was done, and the histomorphology, in fact, revealed this diffuse pattern of diffuse sheets of large atypical lymphoid cells. And when we proceeded ahead with the IHC, it had shown a strong positivity with CD20, with a moderate PAX5 and few scattered CD30 positive and a high MIB1. So to conclude the IHC, it was positive for CD20, CD79A, LCA, and the MUM1 BCL6 was like more than 30% positive with a moderate PAX5 with a high Ki67 of about 80%, and BCL2 being about 20 to 30%, and CMYC also being about 20 to 30%, with negative for being CD3, CD10, CD15, EBV, and the CD30 had actually shown just weak and scattered positivity. So the final diagnosis was in fact given as a high-grade B-cell non-Hodgkin's lymphoma, consistent with a diffuse large B-cell lymphoma transformation. So following this, the report, the patient was in fact given a salvage chemotherapy, with a salvage chemotherapy with rituximab, and she in fact achieved a complete metabolic response following the chemotherapy. And she also underwent an autologous stem cell transplantation in June 2025. And currently the patient is disease-free and is on follow-up. So what I want to discuss is the transformation of classical Hodgkin's lymphoma to diffuse large cell B-cell lymphoma is quite rare. As I said, there are literatures which mention about these kind of transformations in case of nodular lymphocyte predominant Hodgkin's lymphoma. So the possible pathogenesis or explanation that has been given is because of the clonal evolution of these Reed-Steinberg cells, which are actually the crippled B cells. Or it can also be you can explain it with the development of a secondary lymphoma. So here comes the importance of doing a repeat biopsy if it is necessary when you have a patient which is not really responding to the initial chemotherapy. So whenever a PET scan report is mentioning it is a disease resistant kind of treatment, if it is like a disease resistant, we need to actually correlate or do a corresponding biopsy to ensure that it is not really a disease transformation. So whenever there are these kind of transformations, and when the disease is like CD20 positive, we can use the drugs like the rituximab, and the patient would be able to attain complete remission as well. So the key learning points that I need to share is that not all residual or progressive classical Hodgkin's lymphoma is a relapse. We also need to consider the transformation. So we need to do a PET scan and a biopsy whenever it is essential and whenever it is suspected, whenever there's a case of a disease-resistant condition. So whenever there is this kind of transformation, we might need to change the protocol and use a rituximab-based chemotherapy, or a stem cell transplantation can be useful in achieving a complete remission of the disease. So early recognition of treatment-resistant classical Hodgkin's lymphoma is in fact quite vital, and biopsy at progression is really mandatory. Transformation, in fact, allows a tailored chemotherapy or a tailored therapy that we can give to the patient in the form of a rituximab-based salvage therapy along with a stem cell transplantation. So these are the key references that I have included in my presentation, which basically mentioned about these kind of transformation of the classical Hodgkin's lymphoma to the nodular lymphocyte, to the DLBCL. Thank you.
So thank you, Arya. Thank you, Arya, for this beautiful presentation. Any questions? That's nice. So let's give her the certification.
Maybe do it see this. The ceiling can and just the much can. Maybe in your case, with one with transfer. Could be ceiling has a regular pieces. It's good, you know, in case of that. Thank you. Thank you, Dr. Baker.
Hi, actually that now we conclude our morning sessions. Now it's the time for group photo. So let's gather together in the back side and we'll go to the front side as well. Please join.
Yeah, yeah, sure. Right? On this, yeah. No, it's actually the same. My master, yes. You want to start?
Yeah. Sure, sure, sure. Just 1 minute.
Something I can ask. Comfort patient.
This side.
Good.
Should we do?
Look.
Just.
And then let's put it under my name so we can know which part. Let me rename it. Okay. Where is the rename option? Oh, yes. Okay. Then we can we can do it, yeah. Copy and paste it in your yeah. Thank you.
Yes, ma'am. Optimization. Yes.
It's closed. How was it? It was okay.
Yeah.
By nature.
Yeah, it's yes.
Not connected.
Well, if we come, I think it's loud right now. Yeah, it will show like the same.
Yeah, but now it's because I want to take just one photo. It's okay to connect.
Into call.
This is okay. Maybe before my presentation, I'll take just one.
Say. I think it's done. Screen share. Yeah, no, I'll just do.
Yeah, she will be.
Are you available as well?
Yeah, her
No, I have
presentation.
presentation afternoon.
Okay.
So better to send it.
Yeah, sure. No issue. If she finds any difficulties, you can just explain.
Yeah.
You can just guide her.
Sure.
Again, it's coming.
Can you connect it to the screen? So let me take one photo of it.
Again, it's. Yeah.
Yeah. Thank you.
So,
So what practical figures? Step one, right? Very. It's good. Oh. That's very sad. It's just Yes. And how is the poster is built? You no, it will be an investigation. So this was the same Dr. Ali was discussing. Dr. Who? The last session. Oh, that was the tissue largest. Yes. Okay. Thank you. So I will take care of this. Sir. And I will and I will pass it right here. But if this should do start of the devices, right?
Yeah, you can.
The break time now.
Yeah, it's break time. It's lunch break. Do you want to have lunch? Um, almost done. Almost done. Time is already done.
Okay, so how's the presentation?
Yeah, I'll let you know which presentation, which one, final?
This one,
This one.
yes.
Yeah, okay. I'll just copy this. I just copied it. Yes, over here.
Okay, can you just let us check everything?
Do you want to see over here?
Yes, yeah. Yeah, well. The nice. Okay, perfect. Okay, good. So now how many presentation before me?
Um, so it's 8, 9. I think yours is 10. 2 more presentation and it's yours.
I will be late.
Hmm?
I will be late. What time is it now?
It's
1:50. So two and then mine. Each one, how much time?
20 minutes, 15
Okay.
minutes, 25 minutes, 15 minutes.
Okay.
Yeah.
Okay.
Good afternoon, dear colleagues. I would like to invite our next poster presentation, Mrs. Lintu Vimish from Qatar, and she will present her work on atypical pneumonia, a cold clue under the microscope. Let's welcome her to the stage.
Linked to
So good afternoon all. I hope you all get energy after the break. So some of you know my face as a chair today's morning session, but right now I'm stepping in as a presenter. Okay, so let me briefly introduce myself. I'm Lindu Vimish, lab technologist from Group Health and Medical Services, Qatar Airways. So today I will be presenting an interesting case titled Atypical Pneumonia, a cold clue under the microscope. So this presentation highlights how a routine CBC surprise leads us to an unusual diagnosis. And also, it reminds us why it matters, especially for flying crew. Let's move on to the introduction slide. So we often faces diagnostic puzzles in the aviation settings, but this case highlights how a lab insights unraveled in an unusual presentation. So basically, it is particularly important in the aviation settings where the cabin crew met faces the unique environmental exposures such as cold stress and frequent travel. So, atypical pneumonia is often tricky and it usually presents with gradual onset, persistent cough, and mild symptoms. The chest x ray results may be normal or non specific, and many times crew get treated with a wide variety of antibiotics but still remain sick. And also, the challenge is routine investigation may not always reveal the clue. And this case reminds us, even in the era of automation, how the manual CBC smear reviews did the role, or it has a vital role still. This is the interesting slide of our presentation. It's a case history. So basically, this case involves a female cabin crew member who presented with respiratory complaints. Initially, her CBC was normal. She was given some antibiotics, but still her condition persisted. She came back on her 7th day follow-up visit. That time, we noticed that her CBC shows an unusual pattern. Let's see what was that pattern. Her RBC count was low, MCH, MCHC highly elevated, and WBC count within normal limits. And the hematology analyzer flagged possibility of turbidity, agglutination, or interference. Let's move on to the slides. So at first glance, these results actually appeared contradictory, like a sampling artifact. Elevated MCH, MCHC with a low RBC count, it often suggests a laboratory error or an interference as well. But this was the starting point of our investigation. So what we did, now the analyzer left us puzzled, like abnormal values and strange flags. So to find out, we did what every pathologist loves to do. We just went under our scope. That was a peripheral smear examination. Yes, we performed peripheral smear and it showed RBC clumps, highly suspicious for cold agglutination. To confirm, we warmed the sample to 37 degrees Celsius and CBC was repeated. I'm just highlighting again to confirm we warm the sample at 37 degrees Celsius and repeat the CBC. Interestingly, the CBC results are normalized. So this abnormality was not an error. It was a genuine cold agglutination phenomenon. Here, you see the difference of CBC results. The first result shows the red arrow mark. RBC was low, 2.45, and MCH, MCHC was highly elevated. In the second CBC smear, shows after we warm the sample, these all are get normalized. So that was a clear demonstration of temperature played a vital role. So this is the peripheral smear images that showing RBC clumps on the smear. So what happened here? The microscope turned a doubtful analyzer result to a diagnostic lead. And indeed, like we want, the results are normalized as well. Next is another interesting slide. Voila, warming changes everything. Let's see how was our diagnostic pathway. So based on these findings, we recommended to do a direct Coombs test, which came back with positive results. Given her occupation and radiology findings, next we suggested to do a testing for Mycoplasma pneumoniae, since it is a common cause of cold agglutination. It was IgM serology. So the IgM serology came back strongly positive. So thus the final diagnosis is atypical pneumonia due to Mycoplasma pneumoniae with secondary cold agglutination reaction. This will be the discussion slide. The important thing here, the crew may get treated with wide variety of antibiotics and may get the chance of hemolytic anemia. So here, briefly about atypical pneumonia, as I discussed earlier, it's a gradual onset, persistent cough and mild symptoms. Chest x-ray may be normal or non-specific. About cold agglutination, it's an autoimmune hemolytic anemia triggered by cold. Here, the IgM antibodies bind RBC at low temperature. It's often secondary to infections like Mycoplasma, Epstein-Barr virus, etc. About Mycoplasma pneumonia, Here you can see that it's the smallest free living organism which lacks cell wall. Spreads via droplets, incubation period is 1 to 4 weeks. So here you can see that why the patient or the female cabin crew did not initially improve the symptoms because this mycoplasma has no cell wall. So beta-lactam antibiotics will not affect. Another important slide, why it matters for flying crew. Yes, this case is especially important in the flying crew because frequent travel, which increases the exposure to infections, and cold in the flight environment will always trigger or worsen the cold agglutination disease. And repeated cold exposures, which lowers the threshold for symptoms as well, and close living, and of course the working quarters that increase the infection spread easily. So what seems it's like a small lab artifact may actually have serious clinical relevance in this population. Then what are the lessons for laboratory? Yes, the cold agglutination may mimic lab error. If you see an elevated MCH MCHC with a low RBC count, don't ignore as a sampling artifact. Think about agglutination, and always the temperature sensitive testing is essential for the accurate diagnosis. And another important thing, the clinical collaboration between the lab and clinicians is always critical to avoid the misdiagnosis. And about the treatment, as I mentioned earlier, Mycoplasma pneumonia organism lacks cell wall. Therefore, antibiotics targeting the cell wall synthesis are ineffective. This explains why initially the cabin crew did not improve the symptoms on with standard antibiotics. Instead of macrolides like a clarithromycin are the effective and safest way. Let's conclude. So here we understood that mycoplasma has no cell wall. So beta-lactam antibiotics are not effective. And also in the era of automation, still the smear have vital role. So I hope you all enjoyed this journey with me from a puzzling CBC to a fascinating diagnosis. On behalf of Qatar Airways medical team, I would like to thank you all of your attention and giving me this opportunity. Thank you.
Thank you, Mrs. Rimish. Oh, sorry. How should I turn it off? Thank you, Mrs. Rimish, for your excellent presentation. It was very interesting and going back to how to make this experience. Inclusion to the picture. Right now. No, thank you. Our next Our next speaker is Dr. Advait Karmarkar from India. He will be presenting on genetic guardianship, pigmentation mutation, and its impact on plasma cell disorders. Please welcome him on the stage.
Hello. Hello. Yeah. Good afternoon, everyone. First of all, I'd like to thank you to giving me this opportunity to present in front of everyone. My topic for today is genetic guardianship, TP53, and its impact on Parkinson's disorders. So these are the basic hallmarks of cancer. I won't be talking about all of them. It's just the newer ones which have been come out in 2020, 2022. So one of them is unlocking phenotype plasticity. This talks about the cancer cell gaining the ability to change its identity and de-differentiating them into stem-like states. Why it matters is it makes the tumors heterogeneous and therapy resistant. And a good example of that is AML. Another new hallmark that has come through is non-mutational epigenetic reprogramming. In this, there is the gene expression doesn't change. There's a rewire of gene expression, but the DNA sequence doesn't change. What this causes the same sorry, yeah. What happens is the mutation can be same, but the tumor in these cases behave differently, and that causes a problem with the treatment and drug resistance as well. Another new hallmark which has come through is polymorphic microbiomes. In polymorphic microbiomes, a good example is Helicobacter pylori. In these cases, the host microbiome influences tumor initiation, progression, and therapy outcomes. And this microbiomes modulate inflammation, immunity, and drug metabolism as well. So proto-oncogenes are normocellular gene regulate help in normal cellular gene regulations. A good example are growth factors like platelet differentiating growth factors, growth factor receptors like HER2, signal transducers like RAS and ABL, and transcription factors like MYC, and cell cycle regulators. What happens when proto-oncogenes are overexpressed and they cannot be stopped, they turn into oncogenes, which cause gain of function mutations, and this leads to tumor in most cases. And they drive uncontrolled cell proliferation. A good example is signal transducers as RAS, which and then MYC and BCR-ABL, which is a known. Yeah. So these are oncogenes and proto-oncogenes. These act as accelerators, which accelerate the cell cycle stage. But in some cases, like TP53, which act like brake and cause tumor suppression function. So that's the topic for today, TP53. It's located on chromosome 17, and it's known as the guardian genome because it halts and it regulates cell cycle depending on the damage to the DNA. Its function is if it senses a DNA damage, it causes a halt in the cell cycle, usually in G1 or G2 phase, which then gives rise to it also activates DNA repair function and helps in gives the cell a chance for to fix the mutation and continue the cell cycle. In cases where the repair is irreplaceable, then it goes through with apoptosis and senescence. It also helps in metabolism and angiogenesis, but TP53, the main function is repair and halting of the cell cycle. So in cases where there's loss of TP53, the regulation of cell cycle doesn't happen. The cell bypasses all the checkpoints and causes gain of function and increased mutation. So this is just the same thing again, activation and the checkpoint sensors are seen. P53 halts the cell progression through cell cycle and activates DNA repair functions. This is just a overview of what I've spoken about. The top part is the stressors that cause TP53 mutation, and once stressors like nutrient deficiency, hypoxia, DNA damage, or oxidative stress causes P53 mutation to occur. If P53 to activate, this causes a stop at the G2 or G1 phase. In cases where cell cycle doesn't occur, then it goes through the metabolic switch, the dormancy, or the cellular differentiation. Where it occurs, it usually causes DNA repair, depending on if the cell is still recoverable. If it's not, then it goes through with apoptosis and necroptosis. So depending on type of mutations, TP53 has a varied variety. One is missense mutation, nonsense mutation, frame shift, splice, and silent. These are usually seen in missense is seen in breast cancers, nonsense is seen in colon cancers, frame shift is seen in glioblastomas, and I have a case on it. I'll be speaking about it in this slide. So we had this patient a few years ago. The patient is a 59-year-old male. He came to us with already diagnosed anemia and thrombocytopenia, and he was a known case of solitary plasmacytoma. At the intradural site, the lesion was at D3 vertebra and included the body and the transverse process. He was operated and had radiotherapy for the same. So we were actually puzzled of why he came through. The patient presented with complaints of fever, cough, bilateral lower limb pain. He had tingling sensation and weakness in the lower limb throughout. And on examination, no other findings were observed, and all his vitals were in normal limits. We went through with a few investigations which revealed inflammatory markers to be high. CRP was raised, ESR was raised. We also did a triple H test in which his HbA1c was reactive, HIV and CV were normal, and his clinical chemistry was also within limits. So this is his CBC count. As you can see, he had mild leukocytosis and mild thrombocytopenia as well. So this on his medical findings, this was the picture seen. As you can see, a few plasmacytoid cells were revealed, and this led us to do a bone marrow aspirate. On bone marrow aspirate, this is a low power and a high power image of the same patient. Hypercellular marrow was seen, and a few atypical suspected plasma type cells were seen. And as you can see, this one with the eccentric nuclei and perinuclear HOF, which could be seen, and basophilic cytoplasm was also seen, which made us suspect plasma cells in his bone marrow, excessive plasma cells. Adequate marrow particles, marrow was hypercellular, relatively suppressed, and erythroid and myeloid CDs were not seen at all. Everything was replaced by plasma cells, and around 85% mature and immature plasma cells were seen in his bone marrow. And yeah, I think there's a binucleated cell form seen here as well. This was his biopsy. Again, hypercellular in nature, and this showed atypical cells throughout, which made us do a bone reticulin stain. Reticulin stain revealed a grade 2 fibrosis, which is seen here. And we also did a cytogenetic studies, which revealed three things. First is a trisomy of chromosome 11. Then deletion of 17p and 13q was also seen in this, which 17p is the main one which made us suspect TP53 deletion, and further studies were done. In further studies, we did his protein levels were normal, albumin was decreased, globulin was increased, which caused the AG ratio reversal. And on serum electrophoresis, his M band there was an M band spike seen, and free kappa was 620. His kappa to lambda ratio was also 32.63, which was very high. So we concluded the diagnosis of plasma cell leukemia of this patient. So the diagnostic criteria for plasma cell leukemia has been changed according to the IMWG group. Initially, we needed at least 20 or more than 20% of plasma cells circulating in blood, and this caused the incidence of PCL to be only 1 to 2%. This was back in 1974 and still in 2013. In 2021, they reevaluated the criteria causing PCL to be circulating plasma cells of more than 5%. This revealed the incidence of PCL to be 3 to 4%. So at least it caused, even if it's a small percentage, it's still double the percentage. Then the risk stratification score. if according to the international staging system, his beta 2 microglobulin serum less than 3.5 and albumin more than 3.5, it could be a low risk patient. Whereas if his beta 2 microglobulin goes to more than 5.5, you could consider this patient as a high risk model. In our patient, since the patient was a 17p13 deletion, so the patient was already considered a high risk patient in this case, according to the revised international staging system. Management of plasma cell leukemia needs to be aggressive and a lot of. So the overall treatment usually is oriented towards cortisone and lenalidomide-based multiphase therapies. There are quite a few therapies which could be used in depending on primary or secondary plasma cell leukemias. And this patient, the specific patient you're talking about, we couldn't follow up with him because he went to a different hospital for therapy. But as far as we know, the myeloma-directed therapy was started for this patient. In remission criteria, if the patient comes back to you and the plasma cells in peripheral blood are totally absent, but there's a less than 5% bone marrow's plasma cells seen in bone marrow, the patient could be suspected to be in complete remission. Whereas if the patient has reduced number of M protein levels and less than 5% bone marrow, whereas his M protein levels in urine are still less than 100, then the patient has a good response to the therapy you're giving. Whereas if the patient is still plasma cells are present in his blood around 1 to 5%, and bone marrow still has 5 to 25% plasma cells, the patient could be suspected to have a partial response to the therapy you're having. Whereas a patient with reappearance of plasma cells or increased number of more than 10% increase in bone marrow plasma cells, the patient could be suspected to have a relapse of PCL. These are my references. So to conclude, high suspicion for PCL diagnosis is necessary, and if the patient shows plasma cells or any plasmacytoid cells could be seen, peripheral morphology, marrow findings, and cytogenetics is the key to make a clinical diagnosis. And obviously need to improve therapy and follow-up is also necessary. Thank you.
Thank you, Dr. Kamara, for your engaging important talk. I would like to invite Dr. Omar Ali Islam Ali to Hamza University. Further, if you invite Mr. Tahim Al-Khanaizi from Bahrain, who will present on digital pathology survey reality versus practicality. Please welcome him on the stage.
Thank you. Good afternoon, everybody, and thank you so much for the invitation. I'm really pleased to be here to give a talk about digital pathology, which is, I believe, in parallel with the theme of the conference. I really appreciate the opportunity. Thanks. Just wanted to have a quick question to understand the audience. How many is coming from histopathology background? Histopathology? Okay, great. Thank you so much. So at least so I know how to adjust my presentation accordingly. Okay. So as you can see from the title of the presentation is Digital Pathology Survey in the GCC, Reality and Practicality. Are we there with the digital pathology? So everybody is talking about digital pathology. In each and every pathology conference, people talk about digital pathology. So what is the reality and practicality as well? Are we practical when it comes to digital pathology? Not only within the GCC countries, but also comparing ourselves with other countries and regional countries. So in this presentation, I would like to share my survey that I conducted a few months ago. And the survey title was Histopathology Lab Automation. Each lab in the lab or each department within the lab, like microbiology, molecular, there is significant automation. But in histology, are we automated or still we are behind? So this is the main objective of the survey. The survey was conducted between 8th of March to 20th of April of this year, and it was by invitation, very selective. The survey was given to histology lab supervisors or lab director to get the accurate information. 22 questions were in the survey related to slide preparation, instrument automation, integration of instrument with the lab information system. It's very important. You have the complete automated machine, but is it integrated with the lab information system or the system or not? To complete the automation. And last but not least, sometimes when there is a question, the answer is yes, it goes automatically to the next questions. If the answer is no, then it will skip. So this was the design of the survey. These are the steps in preparing the slide in histology lab. I'll just get the arrow. No pointer. Where is the pointer? Okay. Okay, good. So these are the steps to prepare the slide. From the time we receive the sample until the case is reported. So in my presentation, I will focus only in one area of the survey, which is digital slide scanner. These are the steps, again, from the beginning to the end of reporting the case, from this time we receive the sample until the time it is archived, actually, not only reported, until the time the sample is archived. And again, I will be focusing on the digital pathology part. There are basically, the whole presentation is about 3 questions. The first question to the lab directors or the histology lab supervisor, do you have digital slide scanner? Of 102, 32 says yes, they have. So the percentage is about 31.4 of the labs within the GCC that participated in the survey, which are 102, 31 says they have digital scanner. The next question, when they say yes, it will go to the next question. Do you have a digital slide scanner and how it is used? Is it used for primary diagnosis, secondary opinion, primary and secondary, or even not in use? Some labs say it's not in use. They have it, but they don't use it. Some labs say it is used only for secondary opinion. Sometimes says it is used only for primary and secondary opinion. Some labs says it is used for primary diagnosis. The third question, if you have digital slide scanner, what is the percentage of daily slide scanned and shared with the pathologist? That's very important. You have it. Do you use it once every day or you use it heavily, efficiently? Again, not in use, the same number. They have it, but they don't use it. Less than 10% of the workload is the majority of the scanners. You can see the percentage is about 37%. 10 to 20% is this area, the people who are using it, and so on. So not much. These graphs in numbers These are the countries that participated in the survey. From Saudi, 52 labs, which is a good representation of the big country. From UAE, 18 histology labs. These are all histology lab only. Kuwait, 11, Oman, 9, Qatar, 6, and 6. Number of slide scanners in each lab. 25% of the lab who have in Saudi have slide scanner, and the same thing in other countries. What was significant here is Kuwait. Kuwait has high percentage of scanners, 91%. So out of 11 labs, 10 labs have scanners. And there is a reason for it that I will highlight in the next few slides. And this is the utilization of the scanner also. So this is more than 50% utilization, only 3 labs. So if you have a machine in the lab, and if you use it below 50%, it's considered inefficient. If you use it 50% and above, it's considered to be efficient utilization. So in the Gulf, in the GCC countries, only 3 out of 102 slides, or 3% of histology labs within the GCC are using slide scanner efficiently. The rest are not using it efficiently. Even some labs are not using it basically. And 10 labs are using it below 10%. How it is used? For primary diagnosis, second opinion, primary and second opinion are not in use. So this one is, we know some labs are not using it. For primary diagnosis, only 3 labs for primary diagnosis, which means that the slides, instead of giving to the pathologist will look at the slides digitally. So 3 out of 102 labs are using it digitally for primary diagnosis. Second opinion, this is very interesting. 10 labs are using it for second opinion. So they scan the slide and they send it to wherever in the world to get the opinion. For primary and secondary is the large number of labs. So some labs are using it for a primary and as well as for secondary opinion. Discussion now of these results. First, I would like to have 5 points for the discussion. GCC geography and population density. It's very important to understand how these machines are distributed. Because digital means, like radiology, when you use the digital radiology, you don't have radiologists in your area, you send them the images. Same thing in pathology, you don't have the pathologist on site, you send the slide somewhere in the world. So distribution is very important of the people because that will determine the need of digital pathology. Let's say that this is everybody is in this room and nobody is outside. So I don't need digital pathology because everybody is here. But if people are distributed in different areas, then there will be more need of digital pathology scanner. Availability of histology, histopathology subspecialty, and ancillary assays. So people working in the lab, histology lab, they understand this. Histopathology is not one specialty anymore. There are a lot of subspecialties. Government versus private labs. Who is getting it? Is it the private or government? And budget and insurance coverage. Expertise in IT. When we talk about digital pathology, it's all about IT. You have the machine. This is the digital scanner. It is only 5% of the job. 95% comes around it. The system, the IT, the support, the storage. So this is only part of the job. And pathologist interest. If you have everything and people are not interested, what is the use? So you need to have that also in place. So I will discuss these 5 points based on the results that have been achieved from the survey. Geography, GCC geography and population density. So it is the largest country, population is about 35 to 40 million. And you can see how they are distributed in the huge country. So do you think it needs digital pathology? It does need that. High population. It's not like India, of course, where you have in each corner high population. It's a huge country, but for the region, this number. Okay, so you can see distribution is scattered. UAE is contained in one area, about 10 million. This is which? Oman, 4.5 million. Again, they are here or in Salalah. So you will find them in these two areas. This is Kuwait, 4.5 million. Again, contained in a specific area. Qatar and Doha and surrounding Doha. And Bahrain, my country. It's a tiny country, but it has 2 million people on it. So you can see from this distribution, which country do you think will need more of digital pathology? Can you? Saudi, right? Saudi is the one that requires more digital pathology. Okay. Now you've seen how many labs in Saudi have digital pathology. If I go 2 slides before, 13 only, but Kuwait has 10. So 91% of the labs have digital pathology, but in Saudi, only 25%. And the way it is used also, this is the way of usage of Saudi. Not in use, 4 machines are less than 10%, 3 machines are 10 to 20, and 1 machine is 20 to 50%. And there is no efficient utilization, despite the large country and the more need for it. This is a survey to support my finding. This is a survey conducted by Dr. Andre. He's from Japan. He's a friend of mine, and I took permission to use some of his slides. He's pioneer in digital pathology. So he conducted a survey in 2024 last year, and I participated in the survey also. So this is the whole slide imaging, which is digital pathology scanner availability in Asia. You can see the distribution. China, and his finding actually consistent with my finding. Kuwait has big number of slide scanners, and you can see the countries. Saudi is here, 10 to 25. Bahrain is here, 10 to 25, and so on. Some countries don't have or very minimal digital scanner. So that was about the distribution of the digital pathology with population density. Now, when do you need digital pathology? You need it when let's say that you have a histopathologist in your lab. That pathologist cannot cover everything. He will cover the general, but when it comes to very difficult cases, lymphoma, brain tumor, whatever it is, that case needs to go to a specialist. Subspecialist could be any of these, which we have in our lab, Express Diagnostics and Research. So we have all these subspecialties, even forensic medicine or forensic pathology, general dermatopathology, renal pathology, and so on. 15 subspecialties. Not only subspecialties, you need the ancillary tests. Let's say that you have this tumor, but this tumor, without supporting techniques, you cannot get diagnosis, like immunohistochemistry. This is a big panel of immunohistochemistry supporting the pathologist, fish markers, and fish probes for solid tumor, lymphoma. It's needed to give the appropriate diagnosis, as well as molecular. So molecular is needed to give accurate and precise diagnosis of the case. So having digital pathology alone, without ancillary testing for second opinion, again, it's not an efficient use of the machine. These ancillary tests, in my opinion, are not available in the places where there is digital pathology. So you need to have these ancillary tests in order for the person in the lab to use digital pathology efficiently, to give accurate diagnosis and they utilize the machine. my third point is government versus private. So again, these are the countries with the same table that I've showed in the previous 2 or 3 slides. This is the number of digital scanners, 32, which is 51%. Government labs have 18 out of 32. Private hospitals labs, 5 out of 32. Semi-government, because there are categories that are called semi-government hospitals, 13. And reference lab. Reference lab means a lab, stand-alone lab that works with everybody, 7. So you can see majority are government labs. And if you look at these 18, majority will go to where? Kuwait, percentage-wise. Saudi 8, but percentage-wise, Kuwait is higher. So 7 for Kuwait only, out of 10 scanners in government. Digital pathology not in use. There are 6 machines that are not in use. Okay, I understand why they are not in use. Maybe they are newly installed, or they brought it, something was missing. So let's assume that this is acceptable number, that these 6 machines are not in use for some reason or another. But 2 of them in government, 1 of them in private hospital, 1 of them in semi-government. But what surprised me, 2 are in reference lab. These reference labs are supposed to be commercial labs. So they don't pay until they make the study, whether to use it or not. However, 2 reference labs have digital scanners, but not in use. Expertise, this is extremely important. I think this is more than 70% of digital pathology. If you have the scanner without good infrastructures with the IT, it is useless. So actually, I asked our IT team to give me what they need to install digital pathology. So this is not my words, it's from our IT department. So these are the skills that IT person need to have. And these are the infrastructure, either hardware or software. And this is basically a layout from one of our digital scanners that we installed in Dubai recently. So IT is 70% of the job when you get the scanner. You can buy the scanner with 100K, but you need to spend good amount of money also on the IT department, not only on the hardware, but also on the soft skills of the people doing the IT part. Not only that, each system had different requirements. So these are different scanners. Some of you might be aware of them. I'm not finger pointing to any of them, but these are the common ones available in the market. And each one has different requirements. So you need to be aware also of the different requirements of each one. Lab information system. Again, it's also part of digital pathology. You have digital pathology, you have good infrastructure around it, you have good software, good hardware, but you don't have supporting lab information system. So you need to have a good lab information system to support digital pathology. Not only lab information system, anatomical pathology lab information system, APLIS, has to be perfect to have good utilization of the system. So this is again from Dr. Andre presentation, where he shows which labs have good lab information system, APLIS. Surprisingly, if I go to UAE, United Arab Emirates, 51 to 75% have good lab information system. Where is the remaining? It's supposed to be strong information system. I don't know where is Bahrain, my country. I hope it's not at the end. Is it at the end? Where, how much?
Below the Kuwait.
Below Kuwait? Where it is? It's up. Good. So you can see that this is infrastructure also. It is needed, whether we like it or not. You cannot bring your Excel sheet, Word document, basic for this kind of, it has to be appropriate lab information system. Okay, barcoding. You will put the slides in the machine. It's not barcoded. What is the use? So barcoding system has to be there also. So you can see the statistics from the Friendly survey. If I go to Kuwait, that's very interesting country, really. If I go to Kuwait, it's always high. High. Why do you think Kuwait is having the best? Anyone? I will go to one slide, and I need your interpretation for that. Government versus private. Look at Kuwait. Why do you think Kuwait has a good infrastructure? Anybody? Any guess from the back? There you go. Government. They paid. They pay the money. High percentage in government. They pay. Private doesn't pay. So government supports this project, and they have a huge project for the whole government in Kuwait. So Kuwait is paying, and Kuwait market, unlike UAE, I don't know how many of you have seen Kuwait market. Anybody have seen Kuwait market? I think the people in the back are from the marketing. Have you experienced Kuwait? Nobody experienced Kuwait? Kuwait is basically government. There is no private job, no private business. It's all government. So government is supporting such projects. It matters. UAE, private, semi-government, government, it's mix of everything. Okay, so I'll go to my last point, pathologist interest to use digital pathology. This is again from Dr. Andre, from his survey. There is a good number of pathologists are not interested in digital pathology. Good number, it's not bad. Maybe because of the generation gap. Still, they are senior pathologists. You give them digital slides. Oh, no, give me the glass slides. I want to see the microscope. What you can say, the confidence they have has to be there. We utilize digital pathology for more than all our second opinion digital pathology, by the way. None of them is glass slides. And our pathologists are within 40s plus minus. So they accept, even experienced pathologists. We have pathologists from the UK, he's 75 plus, and he's into digital pathology. So it depends on the confidence they have when they see the slides. If they are confident enough, they will release it. But if they are not confident, then they will hesitate to release the report. And there are other reasons for not having digital pathology. So digital pathology is not only a scanner, it's not only a machine, but it is a complete system of histology setup all together. You can see the purple boxes are supposed to be integrated with the lab information system. And these can be automation or manual. I'm not going to talk about what is automation, what is manual. It's about the IT integration within the system to get appropriate digital pathology. We've seen a lot of presentations, maybe in this conference, in the future conferences, AI and digital pathology. Everybody's talking about it, right? But are we there in the GCC? If you don't have the data, if you don't have the raw materials, if you don't have the slides and the images, how would you do the AI? I don't have answer for it, so I will leave this an open, non-ended question. Acknowledgement to all participants to the survey, and this is our lab in Bahrain. We have branch in Dubai and branch in Riyadh, and thank you so much. Appreciate it. Any question, any comment, feedback? Keep it here.
Thank you for your interesting and thoughtful presentation. Can I ask Mr. Oran to handle the certificate of participation?
Thank you so much. Thank you. Thank you. Excellent.
Our next speaker is Dr. Kartik Manzareddy from India, who will deliver a talk on the chronicles of morphological and molecular diversity in a case series of real dysplastic neoplasm. Welcome him on the stage. Thank you.
Good afternoon, everyone. My name is Karthik. Today, my topic is the chronicles of morphological and molecular diversity in a case series of MDS, myelodysplastic neoplasms. So, the introduction: myelodysplastic neoplasms are a group of clonal hematopoietic stem cell diseases characterized by cytopenia, dysplasia in one or more of the major myeloid lineages. Ineffective hematopoiesis, recurrent genetic abnormalities, and increased risk of acute myeloid leukemia. The global incidence is like 4.1 is to 1 lakh of population. The morphological hallmark of MDS is dysplasia in one or more myeloid lineages. And this dysplasia can be accompanied by increase in myeloblasts in peripheral blood and bone marrow. But the blast percentage in MDS should be always less than 20%, which is a requisite threshold recommended for the diagnosis of AML. MDS occurs more frequently in older males and in individuals with prior exposure to cytotoxic therapy. So the aim of this study is to perform a comprehensive evaluation of patients diagnosed with MDS by analyzing their diverse clinical features such as age, sex, organomegaly, presenting symptoms, and any other comorbidities, hematological findings, and morphological characteristics in bone marrow, biopsy, aspirates, and linear-specific dysplastic features. So, in addition, the study seeks to establish the correlation between morphological abnormalities and underlying molecular or cytogenetic alterations, such as chromosomal deletion 5q, 7q, 20q deletions, and mutations in TET2, ASXL1, SRSF2, and TP53, and abnormal flow cytometry patterns. So, the study design and setting was in like it is a single observation center case series conducted in our department in Divyai Patil Medical College, Pune. So total we have studied 15 cases, which are positive cases. So in the first case, you can see it is a 73-year-old female. These are the clinical details: fever, joint pains, and everything. So when we uh, did bone marrow aspiration and biopsy, we found it is a hypocellular marrow with trilineage hematopoiesis with increased megakaryocytes. And we got FISH positive for 20q12 deletion in 88% sets. And we categorized it as a MDS with single lineage dysplasia. The next case is 58-year-old male. He's also having hypercellular marrow with dysplastic changes in erythroid and myeloid series with 15% blasts. And in flow cytometry, you can see all the markers which came positive and anti-MPO positive with abnormal blasts around 16%. And in chromosome analysis, there is 46 XY deletion, 7Q deletion. And NGS, we have detected SRSF2 and CRAS and TET2 genes. So the blasts are more than 10%. So we given it as MDS with excess blast too. This is the third case, which is mildly hypercellular marrow with about 15% blast and 24% monocytoid cells and dysplastic features in myeloid and megakaryocytic lineages. Acute leukemia in the background of dysplastic marrow. In the flow cytometry, you can see the markers which came as positive. And in the NGS, mutation was positive for NRAS, TET2, DNMT3A, BCOR, RUNX1, and SRSF2 gene. So we categorized it into MDS with excess blast too. In the fourth patient, it is a 56-year-old male. It is a normocellular bone marrow with trilineage hematopoiesis with dysplastic changes in myeloid and erythroid series. In NGS study, it gave positive for RUNX1 gene. And because of only one positive, we could not categorize it. The next patient is 16-year-old male with markedly hypercellular marrow with dysplastic features. You can see the flow cytometry markers which came positive. And on NGS, NRAS, CBL, and W2 mutations are there. So we categorized it into MDS with excess blast too. The next case is 45-year-old male with hypercellular marrow with dysplastic megakaryocytes. So NGS results are positive for mutation AXL1 and STAG2 genes. So this is the next case, 65-year-old male, normocellular bone marrow with trilineage hematopoiesis with dysplastic change in myeloid and erythroid series. FISH show the result was negative for 5Q and 7Q and 20Q deletion. So like further workup is needed like NGS, but due to financial restraints, we couldn't do. And the next case also the same. Due to the financial restraints, even though we found dysplastic changes in bone marrow aspirate and biopsy, we couldn't follow up the case. So these are the next cases where NGS came negative, but the background is showing like dysplastic changes in bone marrow. So further workup is needed for the more morphological suspicion. But the same thing in India, due to financial restraints, we can't work it out. So here you can see bone marrow aspiration and biopsy slides of some of the patients. In figure 1, the Leishman stain bone marrow aspirate with dysplastic megakaryocytes. In the middle, you can see. In the figure 2, the bone marrow, the bone marrow biopsy of the same patient showing dysplastic megakaryocytes and paucity of erythroid precursors. And this is bone marrow aspirate of other patient, which is showing erythroid dysplasia and dysplastic changes in the form of hypogranular neutrophils with downward shaped nuclei. You can appreciate over here. And next picture shows of the same patient, bone marrow aspirate smear showing a monolobulated megakaryocyte in the center. So this is of other patient. So you can see the dysplastic myeloid cells, blasts, and monocytes. So here you can see dysplastic megakaryocyte, which is in the center. So these are some of the flow cytometry reports. In the first, you can see CD34 versus CD45. So you can see clusters of CD34 positive blasts with low to intermediate CD45 expression. Blast comprises of around 18.6% of total viable cells. Over here, you can see CD33 versus CD117. So blasts are showing expression of both, confirming their myeloid lineages. In this, we are analyzing granulocytic. Here we are analyzing granulocytic maturation. with CD13, CD11B, and 16. And you can see abnormal maturation patterns with promyelocytes around 0.44%, myelocytes around 2.25%, and mature granulocytes around 68.7%. So maturation and you can say asynchrony can be seen in MDS. So these are the different scoring systems of MDS. So IPSS, WPSS, MDA, PSS, IPSSR. Now we are using IPSSR, which is based on cytogenetics. And this is the most recent scoring system, IPSSR, which they have based it on genetic mutations. So this is the proposed treatment algorithm for the patients with MDS for the low risk, high risk, and depends on age. So there were total 15 MDS cases out of 451 hematological disorder cases, which are referred to our unit. The gender distribution is 26.62 is to 1 with male predominance. In the study, the mean age was 52 years with variable cytopenias and no response to nutritional correction as common presentation. Few patients has organomegaly with normal or high serum LDH levels. The marrow was hypocellular with dysplastic changes seen in isolated lineages or all three lineages together. Flow cytometry studies were done in few cases, showing dysplastic maturation patterns and increased blasts in few patients. Varied molecular and cytogenetic patterns seen like DNMT3A, ASXL1, NRA, STET2, RUNX1, SRSF2, 20q deletion, 7q deletion, TP53 mutation, etc. Given the financial restraints, a few patients could not be worked up. A few cases presenting clinically as MDS and with morphological dysplastic changes on aspiration and biopsy were negative on conventional molecular and cytogenetic studies. So the conclusion is the molecular abnormalities characterized by genetic techniques are vital in confirmation and prognostication of cases, which then helps to predict response to therapy and need for newer drug and therapeutic interventions. There is need for higher resolution molecular and cytogenetic techniques like microarray and OGM, which is optical genome mapping, to analyze SNVs, which are missed in routine commercial techniques. Diagnosis of MDS requires an experienced holistic approach. So the take-home message is MDS is considered a rare disease. However, thorough workup is needed and clear prevalence rates. And few structural variants missed on standard of care testing can be worked on newer modalities like optimal genome map. Financial restraints is a major contributing factor in like countries like India, which are low income countries, for better healthcare. And it is one of the major avenues for research in myeloid neoplasms. These are my references. Thank you.
Thank you very much for your interesting presentation. I would like to Dr. Ilhan Kandadas to handle your certification. Thank you.
It's Dr. Nadina from Uzbekistan. I'm passing on the stage today to deliver the presentation on molecular and clinical pathology analysis of undifferentiated carcinoma with osteoclast like giant cells of the pancreas, a case report series. Welcome, Doctor.
Um, I'm very sorry, but my Thank you.
Good afternoon, dear colleagues. First of all, I would like to say thank you, and I'm very honored to be here and presenting our study. My name is Dr. Madina Jahankiro. I'm a practicing pathologist from first private lab in my country, so pathology lab. I'm from Tashkent, and my work focuses on diagnostic pathology and integration of molecular approach in cancer research. So today I would like to present our experience with one of the rarest tumor types of the pancreas, which is undifferentiated carcinoma with glass-like giant cells. It's a rare and aggressive tumor entity. And through this case-based study, we aim to highlight both the histological spectrum and molecular alterations of this tumor. This neoplasm accounts for less than 1% of all pancreatic adenocarcinoma, and it was first described in 1950s. And since then, fewer than 100 cases were documented, and they have appeared in the medical literature worldwide. Why we would like to discuss this theme exactly? Because it has a unique morphology, unlike typical ductal adenocarcinomas. Its clinical behavior is highly variable. Some patients die within the weeks. Other ones, they survive for the years. It's clinically important. Why? Because it's histologically distinct and it shares the same molecular hallmarks as pancreatic ductal adenocarcinomas. The most common symptoms include abdominal pain, jaundice, weight loss, and bowel obstructions. On the imaging, we mostly can see that tumor often appears cystic or solid cystic, and it has uniform smooth margins, consistent with contrast enhancement. In contrast, predominantly solid lesions demonstrated ill-defined borders merging with the adjacent pancreatic parenchyma, as you can see image.
Days 2 কালকে স্টার্ট হবে বলি কিনা What is supposed to happen?
Pancreatic carcinogenesis. As you can see, using the whole genome sequencing of 8 cases, in a recent studies, it was demonstrated that genetic alterations observed in this kind of tumor are closely similar to this, which are identified in carcinogenesis of the pancreatic ductal adenocarcinomas and include activating mutations in the oncogene of KRAS and activating mutations and the tumor suppressor genes in TP53. However, current literature on this neoplasm is lacking relative to other pancreatic malignancies, and our knowledge of this is largely based on a case report series. So I would like to start with our first case. This is male, 64 years old. He was reported with symptoms from the April of 2023, and it was treated in infectious disease in hospital for jaundice, skin discoloration, and dark urine. However, in April 2023, the patient was diagnosed after the CT scan with a tumor, and he went pancreatic duodenectomy, Whipple resection. And we will see the grossing image on the next slide. This is the grossing findings of this case number 1, and you can see on the serosal surface of the duodenum approximately 6 centimeters distal to the pyloric sphincter. There is a well-defined mass measuring 7.5 into 6 into 7, and lesion was firm in consistency, grayish burgundy in color with irregular pigmentation and areas of the tissue breakdown, suggestive of necrosis. On a histological examination, we were able to identify multinucleated osteoclast-like giant cells, which are highlighted with the red arrow. And there was areas of conventional adenocarcinoma morphology, which is highlighted by green arrow. And we were also able to see the neoplastic mononuclears. Well, they are highlighted by the blue arrow, and you can also see this pinkish area, which looks like ossification. On postoperative histology, it was reported as a cell class like undifferentiated carcinoma with a cell class like giant cells, which is great for tumor, with the involvement of duodenum and the regional lymph nodes. So we were able to do the NGS for this patient. It was done on the basis of foundation medicine, and microsatellite status was stable on this patient. TMB was 0, and there was next pathogenetic alterations. There was a missense mutation in a KRAS G12V codon, and it's a classical driver mutation which can be seen in pancreatic adenocarcinomas. There was a mutation in TP53 which leads to the loss of tumor suppressor. There was a loss of CDKN2 and CDKN2B. And there was other mutations with unknown significance. The pathway interpretation of the findings on NGS were including that mutation in KRAS G12V experimental approach to these inhibitors, but there is no targetable therapy for now. And the findings about other molecular alterations you can see on the screen. Unfortunately, this patient didn't have any targetable mutations, and we were not able to provide him any target-based therapy. Take-home message is that although the tumor is a rare histologic variant of the tumor of the pancreatic adenocarcinoma, the molecular background is the same and very similar to the classic pancreatic adenocarcinomas. The case number 2 was a 48 years old male. The CT scan showed a mass lesion located in the pancreatic body measuring 7.1 into 6.6 into 8, with signs of infiltration into the surrounding tissue. The lesion shows invasion into the splenic vein and the superior mesenteric vein, as well as involvement of the splenic artery. On a grossing finding, you can see there is a pancreatectomy specimen with subtotal gastrectomy. There is a large irregularly shaped mass in the body of the pancreas, infiltrating the lesser curvature and lower wall of the gastric body, the antrum. The tumor size was 11.1 into 12.6 into 8.7 on the grossing. And cast surface showed heterogeneous with areas of necrosis and hemorrhage. This is a microscopic findings, which is very identical to the first case, and it contains multinucleated giant cells with polymorphic cells, large cells with a marked aneuploidia, and numerous multinucleated acellular-like giant cells. And there was also residual ductal adenocarcinoma structures present. NGS results showed mutation in KRAS, TP53, and as well as CDKN2A loss. But there was also inactivation of SMAD4, which led to the pathway disruption. You can see the pathway interpretation here. In this patient case, we had a SMAD4 loss, which I said results in dysregulation, and CDKN2 loss results in uncontrolled cell cycle driven by cyclin-dependent kinase 6 and 4. In the case 1 and 2 patient outcomes, in the first case, patient unfortunately declined chemotherapy initially, and he got liver metastasis at 10 months. He was able to complete 1 cycle of gemcitabine and nab-paclitaxel before unfortunately expiring. In the second case, patient was not able to get adjuvant chemotherapy since he had rapid progression, dissemination of the disease, and he expired. At the end of the presentation, I would like to make a conclusion and leave a take-home message. First of all, this is the first institutional series from Uzbekistan in this kind of rare tumor and undifferentiated as a class like giant cell carcinoma, confirms that even the real histological variants, they still share the same molecular hallmarks as in pancreatic ductal adenocarcinomas, but behave unpredictably. Patient outcomes remain poor with conventional therapy and stronger rationale for precision oncology approach. And we need a larger studies of this tumor in the future so we can find better clinical approach in a treatment of this patient and creating the treatment plan and prognosis as well. Thank you so much for your attention.
Thank you, Dr. Medina. Now the chairman should give you the certification. Let's call Dr. into that state. But it's so much influence. And personal attacks. And so, our next speaker is Dr. Ishra from UAE. I'm passing her the stage to deliver the speech on assessment of attitude and risk factors for radiation varieties in breast cancer patients after breast surgeries in clinical oncology department. Respective study.
Good evening, everyone. My name is Ishra Mosri, and I'm a medical oncologist with a master's degree in oncology and nuclear medicine. And today I'll be presenting my thesis entitled Assessment of the Magnitude and Risk Factors for Radiation Dermatitis in Breast Cancer Patients After Breast Surgeries. Despite the proven effectiveness of radiotherapy as a treatment for invasive and in situ breast cancer following surgical intervention, one of the most common side effects that can impact the patient's quality of life is radiation-induced skin reaction. By being observed in over 90% of patients with breast cancer who received radiotherapy, radiation dermatitis is considered the most common adverse effect of radiotherapy, with 30% of patients experiencing moderate to severe presentation. Exploring the risk factors of radiation dermatitis is an essential priority to improve the quality of life of breast cancer patients by providing early detection and management. And however, to the best of our knowledge, there was very few studies about this topic back in my country. Due to the large portion of patients affected by radiotherapy by being the most common side effect, this is what made it vital for us to investigate this problem. The aim of the study was to assess the magnitude and risk factors for radiation dermatitis in breast cancer patients after modified radical mastectomy and conservative breast surgery. Our primary objective was to assess the magnitude of radiation dermatitis in breast cancer patients and to determine the risk factors influencing radiation dermatitis among the breast cancer patients. Our first finding was, according to the distribution of dermatitis among the study participants, we noticed that almost 43 patients had grade 1 dermatitis and 10 patients had grade 2 dermatitis and 3 patients had grade 3 dermatitis. And our overall population was 59 patients, so it was more than 90% as it was mentioned earlier. As for the correlation between type of surgery and degree of dermatitis, it was noticed that between grade 0 to 1 dermatitis, only 9 patients who underwent CBS had dermatitis, and 37 patients who underwent modified radical mastectomy had grade 0 to 1. As for grade 2 to 3 dermatitis, only 7 patients compared to 6 patients from conservative breast surgery to modified radical mastectomy. As for the correlation between onset of dermatitis and treatment-related data, we found that there was a correlation between the dose of chemotherapy received prior to treatment and the duration between radiotherapy and chemotherapy. The shorter the duration, the more severe the dermatitis. As for the radiotherapy-related data, it was associated with the use of post and bolus. So radiotherapy was associated with various radiotherapy-related factors, including post and the use of bolus. It wasn't associated with either receiving prior chemotherapy or not, or the type of chemotherapy received, yet the early onset of dermatitis was associated with the dose of chemotherapy received and the interval between chemotherapy and radiotherapy. It was also affected by the type of surgery performed. Conservative breast surgery was found to increase the patient risk of developing acute radiation dermatitis. Our recommendation that physicians should be provided with proper training programs for radiation dermatitis assessment, especially using the CTCAE grading score. And also patients should be assessed before starting radiotherapy in order to identify the presence of risk factors for radiation dermatitis. And the early detection will make us pay more attention to these patients to help better control treatment effectiveness and optimize quality of life in the oncology patients, and proper health education for patients receiving radiotherapy regarding proper care of skin and not use what to do and what not to do during the sessions. Thank you so much.
Thank you, Doctor. Just stay back for your certification. I'll call Dr. Nadina to give us a So hello all. Actually, here we are closing the session day one and we have coffee break. You can join. We'll be taking tomorrow morning. Thank you. I don't know. I'll get this. I just have to get one photo with my